morning, everyone. Welcome to day 2 of the International Conference on the Future of Medical Education 2021. We are into the third session on integrative medical education and training. Session 3 will outline the contributions of traditional, complementary, and integrative medicine systems. We'll examine the advantages, difficulties, and challenges of the interactions between Western medicine and traditional systems that preceded its advent, and provide pathways for the integrative training of future medical professionals. The chair for this session is Dr. Jorge Berra, an Argentinian medical doctor, MD in pediatrics and family medicine, and director of the Foundation de Salud Ayurveda Prema, that is recognized by the Ministry of Ayush, Government of India. We now request the session chair to commence the discussion. Over to you, sir.
Hello to everyone. Our greetings to all the audience here and all the people which are seeing us all over the world. Hello to all bodies, souls, and mind that are related with this very important topic of integrative medicine. Our first speaker is Padma Shri awardee Dr. H. Nagendra, who currently serves as Chancellor Swami Vivekananda Yoga Anusandhana Samsthana Vyasa in Bangalore, India. He shall speak on the topic applying the principles of ancient medicine to current medical education. Please, Doctor.
Thank you. Thank you all very much for organizing this wonderful conference. We bring greetings to all of you from Vyasa to all the delegates of this conference. I really bring greetings for the great opportunity given to Vyasa for sharing the ideas related to today's topic, applying the principles of ancient medicine to current medical education. As all of us are aware, are you able to see me? Are you able to hear?
Yes, doctor, we are able to hear you.
Okay, thank you. So as all of us know, health is not merely absence of disease or infirmity, but is a state of well-being at the physical, mental, social, and even spiritual well-being. So this is put forth in the form of a schematic here, and you know that is the first quadrant. This is the region of normal health. Our entire system of healthcare should be to move towards the positive health, promotion of perfect health, and that's what yoga also wants. Unfortunately, we get sick, we enter into this region, and the whole of medical system is to deal with the diseases to bring us to normal health. And if we continue this, then the sick man will go deeper and deeper and enter into animal level and then commit themselves. So therefore, our whole objective should be to move towards higher thing. This is what the Ayurveda tells. Samadoshaha, samagnischa, samadhatu, malakriyaha, prasanna atma indriya manaha, swastha ityabhidhiyate. The component of health is physical, physiological, that is dealing with the dosha, agni, dhatu, and the mala, and the psychological, indriyas, five sense organs, manas, and so on, spiritual, the atma, the soul. So the swasthya rakshanam, aturasya vikara prashamanam should be the goal. Promotion of positive health, prevention of diseases, holistic management of diseases, rehabilitation, and rejuvenation. That should be the aim. And according to yoga, it is to be dealt at all the levels, not only at the physical, at the body level, or at the Annamaya Kosha, but at the Pranamaya, Manomaya, Vijnana, Anandamaya Koshas. These are the dimensions which are unseen, but these are the subtle and the causal dimensions. They're called, the Annamaya Kosha is called the Sthula Sharira, then we have the Sukshma Sharira, and then we have the Karana Sharira. So each one of us, according to Yoga Shastra, the Upanishads tells us that we have 5 layers of these things. And the whole system has to be dealt with in its totality to bring the balance. Imbalance is the reason for that. The concept of ill health, therefore, as postulated in yoga, is that the vyadhi or the disease, can be anadhija vyadhi. That means non-stress borne diseases, like the infectious and contagious diseases and the viral diseases coming from outside. But there is a series of large number of non-communicable diseases. They are called the adhija vyadhi, that is the stress borne. In the stress borne, there are two, the sara and the samanya. And this is the concept of the diseases according to yoga. And therefore, if we have to deal with the totality, we have to add on the Ayush systems with integrated approach of yoga therapy, particularly the integrated approach of yoga therapy for modern NCDs. Yoga is acceptable fully to everybody. So there is a need for integrative medicine in Indian medical education. So let us look at our history. In our country, before the dawn of the modern medical system, it was all taken care of by the traditional Indian systems of medicine. That is yoga, the Ayurveda, and the naturopathy, and so on. And there are nearly 50,000 or more publications today available in the field of yoga, Ayurveda, and Ayush systems. But unfortunately, most of the healthcare experts do not know such a thing is available, which are published in Index Journal. Even in 1990, we brought forth and we saw that 33,000 research papers were available at that time, and we gave it to all the people. However, the volume of evidence in the traditional healing methods, since it is not known to practitioners and health administrators, it has not been translated into legally acceptable integrative clinical practice. Although the concepts of the be totally different on the verge of contradiction with each other, if we can understand the subtleties, and we can combine this to bring about a comprehensive approach to total healthcare system. That's what the total approach of yoga does. That is looking at man at all the levels. Essentially, the allopathic system works at the Annamaya Kosha level with its medical, pharmacological, and the surgical interventions and the diet schedule and so on. But it hardly deals with the pranamaya, manomaya, vijnana, anandamaya koshas. And as a result, we have not been able to achieve the needed growth in terms of dealing with NCDs. Therefore, the goal of healthcare development system should not merely be to treat diseases, but to prevent diseases and to promote wellness and relieve suffering from rehabilitation and palliation. And that can happen only when you have the total understanding. Therefore, the principles of traditional healing methods in the Ayush, merging with conventional care, could infuse the practice of medicine with a bio-psycho-socio-spiritual goal of healing the whole person. And in fact, that is contained in the definition of WHO and also in the Ayurveda and the yoga definitions of health. Substituting non-pharmacological therapies of yoga and Ayurveda and Panchakarma and others may reduce the potential iatrogenic ill effects of multiple medications, including the potential for drug dependency and negative side effects. And this can lower the cost while maintaining positive health outcomes. That's the advantage. So look at the research evidence in Ayush systems. In medical school training, relatively little emphasis to preventive care compared to disease management has been given. Many complementary therapies may usefully applied in primary prevention as well as integrated in secondary and tertiary efforts. So examples include dietary management, yogic asanas, pranayama, mudras, bandhas, kriyas, the stress reduction programs of the yoga and Ayush systems, and use of supplements. So if we can combine the two systems, the Ayush and the conventional allopathic system, they can provide superior efficacy and safety in the management of chronic degenerative NCDs such as arthritis, hypertension, obesity, chronic pain disorders, than using only the allopathic medicine. That's what has to be done. So yoga has one of the most effective and accepted integrative therapies in cancer care, respiratory disorders, women's health, diabetes, hypertension, and so on. In SVAS over the last 40 years, we have been able to produced large number of such research papers published in the highest journals. Nearly 800 research papers have been done. Not only NCDs, there are several traditional therapies for communicable or infectious diseases in the traditional Ayurvedic system. Recently, the Siddha preparation using papaya leaves has been found to be useful in preventing complications in the dengue fever. So what is the way forward for integrative medicine in India, particularly to be translated into clinical practice and also in the education? Available medicine should be translated in clinical practice. Evidence-based medicine should be adopted in conventional medical facilities. Promotion of research on integrating the philosophy and applications of Ayurvedic systems with conventional medicine. Integrative protocol development, validation, and feasibility studies for health problems. Then high quality research design such as RCTs and double-blind studies. Better allocation of funding for research and implementation. And medical graduates right from beginning should be sensitized to know about the principles and efficacy of these different streams. So inclusion of short-term courses on Ayurvedic systems in allopathic medical curriculum and postgraduate curriculum would be extremely helpful. In fact, commencement of an undergraduate medical curriculum integrative medicine will be the most wanted thing in the current scenario. So the proposed outline of the curriculum for the integrative health, what is the rationale? People ask. Predominantly, the curriculum is knowledge-based and lacks the emphasis on skill sets and lack of practical experience and field visits. Therefore, we have to see that the students get exposed to the practical things right from beginning. Even from the first year, they should be able to go into the hospitals or nursing homes and get the practical experience as to how their systems work and how it can be combined effectively. The present syllabi of medical streams, starting with preclinical subjects and exposure to knowledge and clinical skills only in the later parts of the course, seems to be responsible for the poor skill of the graduate. They start going to the medical institutions, hospitals only in the later years. Then relevance of post-clinical subject would be more meaningful when combined with clinical knowledge, theory and practice. And with a systemic approach, with a systems approach, we have to look at things. Then transition of disease demography from communicable to non-communicable disease. In our recent study all over the country, in the Stop Diabetes movement, we tracked 2.5 lakh people all over the country, and we were able to show that the incidence of diabetes has increased much more in the villages. It used to be about 4%, it has come to 10 to 12% in different rural areas. Therefore, we have bigger burden that is encompassing the whole country. So lifestyle is poorly illustrated in conventional medicine, but extensively elaborated in Ayurvedic system. Therefore, there is a clear need for integration through revamping the syllabus, starting with skill training right from beginning. Most medical curricula have similar subjects with slight variation. The experts in all systems feel that contents of the subjects can be reduced for UGC level. So what is the outcome? The medical professionals should be skilled to implement preventive program, promote positive health, treat diseases, and combine the Ayurvedic system, principles of Ayurvedic system with the right knowledge of medico-legal implication. They should also learn to document the medical records meticulously and develop communication skills. So they should learn to see that the records are kept properly so that there can be the uniqueness of this revamped program to systems approach adopted from the third semester onward by integrating the pre, para, and clinical knowledge and skills after getting exposure to introductory knowledge of anatomy, physiology, Ayurveda, public health, and ICT in first 2 semesters. The inputs from all experts to cut down the subject load have been incorporated in our syllabus that we have developed in the encounter. So now we have formed the entire thing and the prerequisites for postgraduate degrees. For example, we have the MD for 3 years, diploma 2 years, certificate course 1 year. And prerequisites for integrative course is 10+2 with NEET clearance, mandatory physics, chemistry, and biology, program direction, minimum duration 5.5 years, maximum duration 11 years, course for 4.5 years, plus rotatory internship 1 year, which has been put forth as usual, And we have been able to develop the full syllabus. We have prepared that with experts from the last 3 years. We have Dr. Nagaraja, Dr. Nagaratna, and many other experts in this field who are well versed with the allopathic system and their limitations. And the UG and the PG courses have been developed. So, in fact, in our university, we are starting certificate and diploma courses from January 2022, and we are happy to join hands. And thank you all very much for your participation. And it will be a wonderful thing to see that we combine together our best efforts to develop a healthcare delivery system which is very effective, with least side effects, with cost effectiveness and evidence base. That's what we have to do. And we wish you all the best and bring greetings to all of you from Swami Vivekananda Yoga Anusandhana Samsthan, our Prashant Kudiram campus. Namaskar, Dhanyavad.
Useful your presentation, that you remember us that we are not only body and soul, body and mind, but there are other parts of our person. And thanks for presenting the curricula, the proposed curricula, integrating different aspects of medicine. The next speaker is Dr. Gita Krishnan, a clinician scientist and officer for the Traditional, Complementary and Integrative Medicine unit at the WHO in Geneva. He shall speak on the topic integration of traditional, complementary and Ayurvedic medicine into undergraduate and postgraduate training.
Thank you so much. Very good morning to all of you. With thanks to, special thanks to Sri Sathya Sai University for Human Excellence for having invited me here. It was a definitely a wonderful opportunity for me to have visited this campus and seen all of you, and also had a great opportunity to meet many of you who have purest of pure minds and thoughts, and that itself has been a blessing for me. And thank you, Dr. Bera, for having done that, and Dr. Anand for having invited me here. I had been asked to talk about a very specific subject, which is integrating traditional medicine into medical education. It's a bit difficult subject in the sense, or it's a very easy subject depending upon how you look at it, because it's a very broad and very wide subject, and we are trying to integrate two streams which somehow doesn't seem to mix together well. We are trying to bring water and oil together and trying to say we have one single fluid moves, which without we being able to distinguish between each other. But that is the whole excitement of it. We have a lot of possibilities there, and I would like to bring few of my observations as a clinician who was working in integrative medicine for about 10 years in some of the best institutes in the world, as well as somebody who worked in policy from WHO side for the past 4.5 years. So I would try to bring them together. Probably it could be quite raw because my thoughts are still evolving, and I would be happy to answer any of the questions at the end of or during the panel discussion. You see, traditional medicine and modern medicine have two diverse ways of looking at things. Like traditional medicine is going from macro to the micro, has a top-down approach and goes from function to structure, whereas conventional medicine goes from structure to function, is a bottom-up approach and goes from micro to the macro. When I say micro to the macro, you see, conventional medicine goes from the molecular level and builds up, trying to find out how that molecule will function in your body. Whereas traditional medicine will look at, okay, how something is, what is happening to the body, and then try to find out what had caused that. So slightly different approaches to the same thing. Like even in the concept of health, you can see that, and you can be very clearly aware that there are two different aspects in WHO. What WHO says and what Ayurveda says, as Dr. Nagendra had very clearly mentioned it to you, that if you will allow me, I would like to, I cannot see that. I would like to take my. Age is catching up. So. Sorry about that, but I think it is better that I read and rather than say something which I am not intending to say. So, like the concept of health itself is very diverse, or rather slightly different if you look at it from different perspectives. So WHO states that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This is what WHO says, and since about almost 50 years, this is what we follow. But a few years before, maybe around 2000 years before, somebody else said something else, which is very similar. So let us look at that. Ayurveda says that swasthya, which is the concept of health in Ayurveda, is a state of optimal physical, functional, responsive, mental, spiritual well-being maintained by a resilient person who, while continually interacting with the environment, society, and other living beings, carries on with the activities of daily living. I think, what would you consider as a more appropriate term of health? Is it something which is a static point where you say that, okay, everything in your laboratory findings are perfect, so you are healthy? Or something which tells you that, okay, you keep on living and your body will try to organize itself as you move forward? What is health? That is the kind of small difference of opinion, but like since it is at the base level, when it comes into actual practice in real life, it has a wide range of differences which actually happens in the world. So that's something which I wanted to bring to your life, or to your notice. And another thing was understanding of disease. That itself is different. So as I told you, modern medicine looks at the micro to the macro, looks at the molecule and find out what it's doing in the body. Whereas you can see the Ayurvedic therapies, or even the traditional medicine, most of the traditional medicine therapies, not only Ayurveda, traditional Chinese medicine or Unani medicine, looks at what happens in the body and tries to find out where are the effects of it, or rather what is causing that effect. So, or rather, it also looks at the holistic effect of one single intervention on the whole body. It is not one molecule goes to one ligand and blocks a protein being formed, and then therefore delivers you a result. It looks at one molecule or several set of molecules goes into your body. It acts in different parts of the body and give you a holistic result. That's how it looks at. So it's slightly different. I'm trying to say slightly different when I say, because these are all medicines, but the ways in which the sciences approach it are different. So we are trying to integrate these two diverse concepts. Clinical choices, end of life care. Yesterday, we had this beautiful presentation on palliative care. Conventional hospital-based care often sees the person as a passive subject whose set parameters of life needs to be maintained in all manner possible. That's what happens in an ICU. You have an ICU patient, then everything in that patient's chart should be perfect. Doesn't matter whether he's alive or dead. So that's the situation. So if the charts are perfect, the patient's relatives outside are happy, and the patient may be suffering. That's okay. But the doctors are happy, the patient's relatives outside are happy, and that is what happens. But what happens in traditional medicine? Traditional medicine approaches to end-of-life care involves interventions to improve and strengthen the individual system in its active efforts to regain health. It is not trying to do something from outside, it's trying to help you from inside. That's how it functions. And at the same time, being observant and sensitive to this active decision not to. You have to stop? I'm sorry. Yeah, right. I made you miss 2 slides. I'm sorry. So, yeah, and nutrition during cancer interventions is another thing which I had felt as a clinician while practicing in the hospital. Conventional nutritional advisors approach the issue of a problem as a problem of calories, needed per day and prepare the diet plan to ensure the required calorie intake. So I have a post-radiation therapy patient lying in the bed without any, like puking if possible, if nobody is around to stop him or her, but being given a pastry because that will give you enough quantity of calories that you require in the minimum quantum of food that you take. Is like you just ask somebody who had undergone radiation therapy, had been lying down trying to recover, asking to be taken a cup of ice cream or a pastry. I don't know, like I wouldn't like to. And that I can tell you, I have not fortunately been like, I had never had to go through that, but that is the situation. So just imagine traditional medicine approaches this as an issue of ability to digest and absorb, holistically viewing the requirement of nutrition, health of the patient, the medication, and digestive and absorptive capability of the patient. So there is slight difference here. And we are trying to integrate these two. And again, what are the reasons why integration becomes very difficult? It is the world view. That's what we are trying to change here. Like the world views in general, among, like if you have 100 people here, almost 70% of them believes and has a world view that science, as we see and as we have studied in our colleges and schools, tells you the most appropriate answer and gives you the most appropriate answer. I do believe that. So I am not saying that somebody else is believing it. I do believe that. So let me say, if we are trying to bring in something which has a different kind of a view, which has evolved from a different worldview, it has a different history, it has a different culture, it has different social structures when it evolved, it has a different educational pattern, the philosophy, it was different, and it also very importantly has different economics. Economics is very important. We cannot forget that, like economics of modern medicine and economics of traditional medicine are diverse, very different. They are sometimes opposing to each other. So we are trying to integrate these two. And this is a little bit difficult thing. We have to put down a lot of effort to understand how to do this integration. So what I was trying to tell you was, I don't have the answer. What I was trying to tell you is that I think that there is a lot of possibility. When we identify the problems, we put them together and try to see how to bring these diverse situations or diverse cultures and diverse flow of information and knowledge together. Defining evidence in integrative medicine is something like, usually modern medicine will go from like a bench to the practice, whereas in traditional medicine it is already being practiced. So we will go from practice-based, evidence-based, research-based practice. Like you actually go from practice, identify a few things, and then you take it back and then go to the desk or bench and find out what you want to do, and then identify what is happening, and then we move forward, and then go back to the clinical practice. So that's what Dr. Nagendra was saying when he said that from Siddha medicine, they have identified the medicine from papaya leaf for improving platelet count in a patient and had been using in dengue fever. So he just mentioned that. So that is actually, it's already in practice. You go back to the to lab, find out how it is working, and then again bring it back to practice. Let me tell you something on robotic thoracic surgery. What is robotic thoracic surgery doing in traditional medicine? I had been practicing in one of the high-end hospitals in in India, where robotic thoracic surgery used yoga as an intervention post and pre robotic thoracic surgery. You have hard big masses in the lungs. Then they do robotic surgery, or they used to earlier open up the chest and take out this cancer. Now they can do it through a small pinhole which is put on the chest wall, and then they find patients with severe pain, because when they put the port in, it actually touches, usually it goes very near to one of the nerves which is under the rib, and when it heals, usually it touches the scar, or the nerve touches the scar, or the scar tissue touches the nerve, and the patient feels pain. There is nothing to be done from modern medicine for that. And then a colleague of mine who was sitting right across to me came to me and asked me, do you have something to do? Because I am fed up with these patients asking me to help them, and I don't have anything to help them. So we had patients who wouldn't wear a shirt or a blouse because they had this pain, severe pain, and they would have loose dress, holding like this, coming to the hospital. And we treated that with Ayurveda. We gave simple medication, external therapy, and we tried whether it is working. It really works. It works much better than any of the drugs which were given by modern medicine. What I'm saying is, traditional medicine cannot do robotic thoracic surgery, but we are good enough in managing the pain which the robotic thoracic surgeon cannot manage. If we combine this together, we have a happy patient. Isn't that what we want? And isn't that what we are looking at integrative medicine? I think so. It's a part of integrative medicine. We should start looking at it. I would like to bring to you the information from another colleague of mine. He's a dermatologist who works with elephantiasis and filariasis. Yes. Oh, it didn't move. Okay. So this is it. So, filariasis is a condition of infectious diseases when filarial worms get into the lymphatic system, and it gets filled up with lymph or fluid in the body, and then the legs become bigger and bigger, and people cannot walk. It's a very debilitating disease. You can kill the worms, but the problem persists. You can treat the disease, but the suffering persists for the patient. What do you do? Modern medicine has nothing to do there, because this is too fine a surgery to be done by each and every lymphatic drainage system one by one. It is very difficult to do it. We have an excellent treatment identified by a dermatologist along with an Ayurvedic doctor sitting together and treating these patients. So there are hundreds of patients who go there. You can see the bottom two pictures, somebody who had reduced improved their leg condition from within a period of 90 days. You can see that. This is for seeing is believing. You see this. It is possible for traditional medicine to work with modern medicine and give better care to the patient. So that's why I am trying to say that from my experience, there are several ways in which traditional medicine can work with modern medicine, which is independently. Traditional medicine can work in a condition where modern medicine exists, where back pain, osteoarthritis, knee, migraine, constipation, etc., can be managed by traditional medicine practitioners. Whereas then you have need-based referrals where modern medicine practitioners can refer to traditional medicine for saying that, okay, I think you worked on this patient, it was very useful, so I am sending you another patient, please look at that. That is possible. And you can create, if you work together well, and if you have good colleagues and good ways of communicating with each other and collaboration methods, you can create integrative programs. We have run pre and post video assisted thoracic surgical programs, CTVS management there are certain conditions after CT, like cardiothoracic surgery, where patients have constipation, which is managed not well by modern medicine, which has been added as a regular program, avoiding all modern medicines in a modern medical hospital using Ayurvedic medicine, stroke rehabilitation, in certain cancer conditions, dengue, reversal of heart diseases, insomnia, etc. We can run programs together. I'm talking about one doctor working for about 7-8 years in a collaborative environment, coming out with this data. Imagine if there are hundreds of thousands of doctors working together, how much of data, how much of patient suffering how much of data we can bring out, how much of patient suffering we can bring down. If you want to bring traditional medicine and modern medicine together, I think there are a lot of essential components which needs to be brought in, which of course is decisive policies, very important. You require very good policies for that. You cannot just imagine that by making two people sit together, they are going to work together. They need to have a reason to work together, and they should be told to work together. Otherwise, they are not taught to work together. They have no reason to work together. So they should be taught to work together, and for that we require excellent policies which will support that. We require strategic investments. If you ask a modern medicine practitioner and an Ayurvedic practitioner to sit in two different corners of the world and work together, it is not going to happen. They have to be sitting together. They should have interoperable, facilities which can be used by each of them together or probably separately, but in the same environment. That is strategic investments. And we require effective implementation. For effective implementation, the most important thing is that the doctor should know how to communicate with each other. I can tell you, I can underline that several times until the page is in a torn off. But I can tell you, if you don't communicate, you cannot collaborate. And if you don't collaborate, there is no integrative medicine. So if you want to train people to create integrative medicine, train them to collaborate, train them to communicate. And we ask them to be comfortable and confident about their own system. It is not, integrative medicine is not knowing somebody else's system. It is, I am an Ayurvedic practitioner. I never prescribe one paracetamol for me, or myself, or my kids, or my patients. If I have to prescribe a paracetamol, I know that that is a requirement. If there is high fever, etc., I go to my colleague and tell him or her that, see, I have this situation. I had given these medicines and it is not working. I want to reduce the temperature. Please give your medicine. It is as simple as that. There is nothing wrong in not knowing somebody else's knowledge and not having somebody else's skill. It is more important to have your skill in the most perfect manner and the best possible manner. That will create integrative medicine, that will create confident doctors, and therefore create communication channels, create collaborative efforts, and bring people to work together in an environment where they can communicate with each other. That will bring integrative medicine so therefore there are 4 C's for integrative medicine to succeed, which is co-location, communication, collaboration, and of course people have to change. Thank you so much.
Thank you so much, Dr. Gita Krishna, for your inspiring and very well presented presentation. Really has added a lot of information for us. Our next speaker, it's an honor to have with us Dr. Now I invite Padma Shri Awardee, Vaidya Dr. Rajesh Kotecha, Secretary of Ministry of Ayush, Government of India, and ex-Vice Chancellor, Gujarat Ayurveda University in Jamnagar, India. He shall present on the topic implementation of Ayush. Yes, I will continue. He shall present on the topic implementation of Ayush programs into medical education training. Dr. Kotecha, it's a pleasure.
Thank you, Dr. Bera, my old good friend, of so many years. Thank you to see you here. And I also thank the organizers to invite me on this, this wonderful conference. I will share first and then I will proceed. I hope my presentation is visible.
Yes, doctor, it's visible.
So wonderful. So actually, I will prefer not to read word by word of this presentation. So at the outset, I would like to flag some problem statement, and then I will finish in time. When we talk about integrative medicine and medical education reforms by trying to include integrative medicine part into the medical education, we have to look at some areas, and I want to compliment Dr. Gita Krishna and Dr. H.R. Nagendraji that a lot of things they have covered. So I will not repeat a lot of things, but I would like to flag from different perspective. For example, when we talk about medical education, it does not mean that we are only having attention to graduates and postgraduates education of conventional medical education. So we have to look at the allied healthcare professionals, we have to look at paramedical, we have to look at veterinary sciences, we have to look at Ayush. Actually, we have to also look at the sensitization of the all other areas of education where primary information about traditional medicine and its role in our life to maintain health is also required. So new education policy in Government of India has a lot of such things to visualization of these to address these problems. Like for example, there is a suggestion of internalization, there is a suggestion of preventive medicine and mutual respect. So they talk about pluralistic choices in healthcare. Healthcare education system should be integrative. But then, when we talk about integrative, again, there is a problem statement is that what we do mean by integration, what we do mean by integrative medical education. This is a question. There is another question is that when we talk about the medical education, actually, generally, what we mean is the medical care and not health. So health and medical care is something different. Health could be an umbrella where medical education, medical care should be included. But health is something bigger than just medical education. The other problem statement is that when we talk about health, we have in our mind is medicine only, but health has so many other areas, like for example nutrition, for example sanitation, clean drinking water, economics, actually education for the community, and sensitize them to take care of themselves and not to go to the doctor in most of the cases. This could be also one of the important aspect. The other is already mentioned by Dr. Gita Krishnan, is skills versus medical care. So when we talk about medical education, generally we mean is information dissemination, but not the skills. Then there is a fundamental difference that Dr. Gita Krishnan mentioned, but I would like to mention from other perspective is why we face problem is because in conventional medical system, it is all reductionist approach. And when we talk about integrative medicine, the Ayush sciences are more holistic. They look at a person as an entire entity and then look at those problems. This is another thing that we have to look for. Then when we talk about the health science researches, generally, in our minds, we consider this as all development of conventional medicine, but it is not true. Most of these health science researches are done by basic science people, and basic sciences actually are the engine for the growth of health sciences. For example, right from radiology, which is a physics or biochemistry or physiology or anatomy or pathology or nutrition. So those are the topics where conventional medical system or allopathic experts have nothing to do. But it's an advancement of the knowledge developed by different sciences, basic sciences, and brought into the mainstream medical education. Then another aspect is that when we talk about the health education, we generally look at technological advancements, and all technological advancements are considered as advancement of conventional medical system. So we have to come out from this. That is what Government of India is also trying to do. For example, Niti Aayog has recently formed a committee. This committee is Integrative Medicine Committee, and this committee is chaired by member Niti Aayog and co-chaired by Professor Bhushan Patwardhan. Both of my earlier speakers, Dr. Nagendra ji and Dr. Gita Krishnan, is also member of this committee. I am also a member of this committee. This committee has been given this task of looking at integrative health policy, which includes research, education, clinical practice, and public health. So a lot of things are happening actually. So what I am trying to convey is that when we look at integrative health education, we have to look at all these aspects. So traditional medicine education will remain. Medical education, conventional medication will remain, but both of these systems have to have integration. Integration is not just cross-pathy. Integration is more of bringing in the knowledge, which is evidence-based, which is established practices, and then respecting each other, and then having more and more information about each other. And there are a lot of such areas where we can think about bringing in quality education in medical field. For example, in Ayush, recently we have a lot of reforms, taking Ayush education into this new paradigm of bringing in technological advancements and Ayurveda, biology, and basic sciences into the mainstream education. For example, we have these new acts enacted, which has a lot of reforms. For example, national eligibility test or postgraduate entrance or national exit or teachers eligibility or joint sitting or commissions, etc. This is very important to look at. In Susu Sanhita, it says that one cannot determine the purport of a particular science by looking at this their own science alone. We have to open up. We have to communicate. We have to know about other sciences also. So what we are doing actually, so we are trying to take on board these competency-based assessments and focus on creating professionals who can work in primary and secondary healthcare settings. When we talk about medical education, we generally create experts who is trained into tertiary care hospitals. And these experts normally, and it is normal that they want to go to tertiary care hospitals. And largely, there is overcrowding of experts into tertiary care, and there is a lack of human resource into primary and secondary care. So we need to put efforts where we get family physicians or experts of both the fields who can actually be employed or be put at primary healthcare systems and secondary healthcare systems. So this is also another area where we need to put our attention. About the Ayush integration within Ayush. Actually, when we talk about integration, we usually talk about Ayush and modern medicine integration. But within Ayush also, there is a lot of possibility of inter-Ayush convergence and integration. So, for example, what we did, that we have made yoga compulsory for every curriculum of Ayurveda, Siddha, Unani, Homeopathy education. So this is a good example where we look at these possibilities. As I mentioned, that when we talk about education, medical education, of course, primarily we are talking about graduation, post-graduation in medical education, conventional education. But we need to look at school education where we need to sensitize them. Then at graduation level, integration of Ayush courses or Ayush electives into MBBS curriculum, or integration of modern medicine knowledge as electives for Ayush education could be one of the options. The another option is that we can even think about post-graduation, opening up for post-graduation of non-clinical subjects for both the graduates. Like, for example, conventional medical graduate can opt for post-graduation in Dravaguna or Rasa Shastra or basic principles of Ayurveda, or the Ayush graduate can opt for non-medical, non-pharmacological courses like physiology or pathology or radiology post-graduation. Then mainly integration for the research purpose in education is possible through opening up the PhD. So research PhDs for integrated research or postdoc level could be one of the options. And these committees actually considering this. Then there's a whole area of Ayurveda biology. Ayurveda biology, for example, 2 universities of India, they recently started this Ayurveda biology program. One is JNU and another is TDU in Bengaluru. And they have started 5 years integrated course of basic sciences in Ayush, leading to researchers, which is also, a very good move, I think, to create a lot of good HR into who understands research in Ayush. Then diplomas in skill development, paramedical courses I already mentioned, and specialized postgraduate courses. NEP also focusing on all these areas of preventing health, mental health, good nutrition, personal public hygiene, yoga and pranayam, and integrated curriculum, including Ayush, are being developed for all these areas at different level. And we are working with different ministries and departments, even school education or higher education or health ministry. We are working with them very closely. These are examples I already mentioned, elective courses for each other. And I also mentioned about the how we can take it up. Then common PhDs, fellowships. There are areas where there is not a lot is being disseminated through medical education, like geriatric care or personalized preventive medicine or genomics, metabolomics. Then integration is also more possible into neurology, mental health, or even palliative care, geriatric care. Convergence of basic science, allopathy, public health, and statistician. This is one of the area where we need to sit together and talk together, because public health is entirely new area where is not disseminated properly in medical education. Basic science is also lacking in syllabuses of both traditional medicine education and allopathic medical education. So we need to look at and reform in the curriculum. Then research-oriented biology courses also is required for the curriculum of at least postgraduate level. There is an example of Vaidya Scientist Fellowship Program. It is a novel initiative. Then these Ayush physicians are exposed to basic sciences, and they have created excellent workforce for research into these areas. So at last, I want to mention this Paratantra Avlokana approach. Paratantra Avlokana approach is gaining insights by looking at other sciences and then enriching our own sciences. So that could be, the solution where we sit together, we visualize, we bring in, which is evidence-based, and we have respect to each other, and we bring in this whole new human resource trained into, at least informed into what is happening into traditional medicine. And then there are a lot of ways at graduation level, at post-graduation, like PhD level, at graduation level, maybe with electives, foundation. At post-graduation level, it is like integrating with each other's opening up of each other post-graduation. And at PhD level is like a real integration of creating workforce who understands each other. So I thank you again for providing me this opportunity and time. Thank you so much. Namaskar.
Ministry of Ayush and all the movements that are doing in order to offer the people a better medicine with the integration of different approach. Congratulations and thanks again for your presentation. Now, I am very glad to present Dr. Sima Malhotra, homeopathic practitioner, former chair, Homeopathic Association of UK, and currently working at one homeopathic clinic. Kindly please look at that there is some error at the presentations in the brochure. Dr. Malhotra will speak about discuss the topic education and training for homeopathic medicine into current healthcare education.
Good morning, dear eminent doctors, my fellow colleagues in the medical profession, and dear students. It is indeed an honor to be here today, this morning, to speak to you on the subject of homeopathy and integrating homeopathy into the current healthcare education. I would like to start my talk today by first giving you a very brief idea of what homeopathy is, because I believe many of you may be unfamiliar with this. So, homeopathy was founded around 25 years ago by, in my opinion, a genius, a man who was far ahead of his time, and even now probably ahead of his time. He was a German physician and chemist by the name of Dr. Samuel Hahnemann, who was born in 1755. Can I have this slide, please? Okay. Dr. Samuel Hahnemann stated that the highest ideal of cure is the speedy, gentle, and enduring restoration of health by the most trustworthy and least harmful way. He dedicated his life to this ideal. The name homeopathy originates from the Greek words homeos, meaning similar, and pathos, meaning suffering or disease. The whole system is based on the principle of like cures like, which is the law of similars. That is, the cure of a disease is accomplished by administering a substance that is capable of producing in a healthy individual similar symptoms to those of the disease to be treated. Can we just stop the slides for a second, please? We're going ahead here. I'll do them. Okay. Can we go back one slide, please? Back one slide through. Yes, thank you. This principle was also mentioned much earlier by Hippocrates, who stated that through the like disease is produced, and through application of the like, it is cured. This idea also has its origins in ancient India and was also expressed by Paracelsus in the 15th century. Here I would like to quote one aphorism from the Organon. This is the book written by Hahnemann, which encapsulates all the laws and principles of homeopathy. In paragraph 9 of the Organon, he states, "In the healthy condition of man, the spiritual vital force, the dynamis that animates the material body, rules with unbounded sway and retains all the parts, of the organism in admirable, harmonious, vital operation as regards both sensations and functions, so that the indwelling, reason-gifted mind can be freely employed for this living, healthy instrument for the higher purpose of our existence." Significantly, it should be noted that homeopathy is a system that recognizes the presence of a vital force. This can be likened to prana in the Indian system of yoga, which is a key difference in the therapeutic models of homeopathy and conventional medicine. Also, I'd like to give you a definition given in the present times by eminent homeopath, Dr. George Vitalkos, in his book, The Science of Homeopathy, as is seen on the slide. Coming back to the vital force that I had just mentioned, in disease states, this vital force ceases to operate optimally, giving rise to functional disorders, which can then further develop into pathological states. So you may wonder, well, what are homeopathic remedies made of? I mean, many times in my practice, people say, oh, are they herbs or something? Well, the majority of the remedies do come from the plant kingdom and the mineral kingdom, and a small minority are from other biological sources. They are prepared by a very specific process called potentization, and this involves sequential dilutions and succussions, which is like vigorous shakings. These processes bring forth the hidden or latent energy of the crude substance, which then acts directly on the vital force to stimulate it to function smoothly and restore the organism gently back to health. Now, coming back to the subject matter, why the need to integrate homeopathy into current healthcare education? Well, let's look at the usage, the global usage by patients. It has been increasing exponentially worldwide over the past few decades, and it is now practiced in around 85 countries in the world. As you can see on the next slide, there's many countries mentioned there, and of course there's many more in which it is practiced. Out of all of the countries in the world, India undoubtedly has the largest infrastructure with approximately 300,000 300,000 practicing homeopaths. And the other stats you can see on the slide there. In India, it has been a recognized system of medicine here since the Homeopathy Central Council Act of 1973. And it is presently the second most popular systems of the Ayush systems after Ayurveda. The teaching and training of homeopathy here is identical with other medical systems, with a 5-year degree course leading to the BHMS qualification. India also has the highest number of colleges worldwide which are solely dedicated to teaching homeopathy to degree level. Clearly, the enormous government support, coupled with the vast number of experienced and qualified homeopathic doctors in India working in primary healthcare, makes for an ideal model to be replicated by other health policy makers of other countries. It is interesting to note that even though homeopathy originated in Germany, this system has found more patronage in India because of its compatibility with Eastern philosophical thinking, and so has blended well with the ethos and traditions of India. I would like to just highlight now another reason why it should be integrated. And for this, we can look at the advantages of homeopathy. It is very safe, gentle. Practically, side effects are non-existent. And this makes it's very useful in chronic conditions. The next slide I'll show you will show you which chronic conditions it tends to be more useful in. However, it's also useful in many acute conditions, including epidemics. Numerous studies have concluded it is extremely economical compared with allopathic medicines, and so on. Very easy to take. Naturally, it's very holistic. We consider the whole patient and not just the disease in isolation of the patient. I'll just show you the chronic conditions there. Incidentally, in the treatment of women's ailments, it has tremendous scope, especially in the prenatal stages. I've noticed that the number of cesarean sections, especially in the UK, have been increasing of late. And the intervention here of timely homeopathic remedies can reduce significantly the need for such operations. And indeed, even many of the ailments that the pregnant mothers suffer, for example, morning sickness and so on, can be really wonderfully helped with the homeopathic remedies. In fact, if I just may mention just briefly here, recently on the news in UK, it was highlighted that some pregnant women were even committing suicide because they had severe vomiting episodes during pregnancy. And obviously allopathic drugs need to be avoided in such cases. So here we have wonderful remedies for this type of condition. Even if you look at all those chronic conditions, if you just consider for a moment, if 50% of patients in these categories were treated homeopathically, you can well imagine the enormous reduction in pressure on any healthcare system in the world, as well as the enormous savings in costs. Coming to the education now, studies have shown that medical students have felt that they have a lack of knowledge when it comes to homeopathy and indeed other complementary and alternative health systems. And in view of the increasing usage by the public, they felt that they needed to have some basic knowledge if they are to confidently refer patients to such practitioners in the future. And some students also acknowledged weaknesses in the current biomedical model and believed that therefore other models should also be explored. The holistic principles of homeopathy and indeed other systems was also seen as a motivational factor to further explore and understand the same. So what are the changes that can be implemented? Well, the inclusion into the medical curriculum, which is the subject matter here, is absolutely vital. As a suggestive framework for this, 1 week could be exclusively devoted to learning homeopathy coupled with clinical training, where students sit in with an experienced homeopath in a clinical setting. This would be of enormous benefit. This extra week, if it is difficult to include, then the degree should be extended by a little. Yeah, I'll come to the next. I believe this is doable if education providers have the will to do so. Such training should also be given at postgraduate level and beyond to experienced doctors and to other healthcare professionals as part of their mandatory CPD courses. Some medical accreditation bodies in the US and other countries have endeavored to promote CAM, which is complementary and alternative medicine content, into the medical curriculum. However, the amount to date has been disappointingly low in Western countries, sometimes as much as 5 hours in the whole 5-year degree course. Even as an elective option, I think this would not be good enough, because only a minority of students would benefit, and then the consequences of this would be minimal. Difficulties and challenge in the, looking at challenges now, difficulties often arise, again, as has already been mentioned by one of our previous speakers, is because of the philosophical divergence of conventional and homeopathic approaches to health. This has often resulted in significant professional tensions between homeopaths and conventional doctors. Here, as an example of such divergence, is the concept in homeopathy of the presence of a vital force or vital energy existing within us all. The other point of contention for scientists are that the ultra-high dilutions very often employed in homeopathy. Scientists argue that the homeopathic remedy is diluted to such an extent that no molecules of the original substance remain. So how can the remedy be effective as it is basically not there? But clinical results very much show that the remedy is still effective. Hence the paradox. The problem here is that some scientists explain the positive clinical results as a mere placebo effect. However, this conclusion is not justified, as such highly diluted homeopathic remedies have repeatedly proved clinical effectiveness in treating animals and infants and young children. So how can it be a mere placebo effect? Rather, scientists, in the spirit of true inquiry, should accept the need to investigate further this anomaly. The homeopathic explanation for this is this: that yes, it is true to state that no molecules of the original homeopathic remedy exist in these extremely diluted solutions at the molecular level. However, the remedy does still exist in the solution, but at its energetic level. Physics has proved through nuclear magnetic resonance spectroscopy that indeed there is an energetic difference between the highly diluted homeopathic solution compared with a pure alcohol and water solution. Other physicochemical methods also demonstrate that the scientific evidence does indeed exist. And so to say that there is no scientific evidence for homeopathy is simply untrue. Also, studies have been done to understand the molecular mechanisms of biological responses to the potentized remedies. This has been shown through the existence of nanoparticles, and various other mechanisms have been studied, which are too numerous to mention here with the time constraints. Don't we say that energy and matter are two sides of the same coin? In fact, matter and energy are interconvertible, and ultimately everything is energy only. So to conclude here, it is the electrodynamic energy of the original homeopathic remedy that is the active ingredient, which acts directly on the vital force in the body and not, it acts directly on the vital force in the body and not directly on the cellular level, meaning the blood and the tissues and so on. More research is needed to develop and demonstrate this. We have to accept that perhaps our current methods of testing are not sophisticated enough as yet to do this fully at present. However, we should not conclude, therefore, that this phenomenon does not exist at all. Another difficulty faced by homeopaths is in regards to random controlled trials, known as RCTs. Now, this is the gold standard for evaluating homeopathy at present. However, these trials are quite adequate for evaluating allopathic drugs, but when it comes to homeopathic remedies, it is totally unsuitable and quite unreliable method. As homeopathy is such an individualized treatment, so these tests cannot be relied upon, to be fair. And there are more suitable tests here that have been shown to be effective. And these are the ones that need to be considered more seriously by the medical bodies in this condition. There is no doubt that conventional medicine, along with the use of cutting-edge technologies in advanced diagnostic and surgical procedures, has made a huge contribution to the health of the population. However, it has also produced its fair share of undesirable outcomes. Indiscriminate overuse of drugs has produced drug resistance, especially to antibiotics on a vast scale. Additionally, it is accepted that iatrogenic conditions exist on an enormous scale. These are the ones mostly due to the adverse drug reactions, side effects, and drug interactions in polypharmacy. This catastrophic impact is slowly being realized, possibly too late. To wind up now, surely the vast underusage of homeopathy as well as other systems needs to be addressed if we are to have any hope in dealing with the present crisis in healthcare, where increased levels of chronic illness, not to mention the present pandemic, escalating health costs, as well as a growing shortage of doctors in India. In rural areas, this can be as much as 1 doctor to 10,000. In Western countries, also long patient waiting lists occur in community and hospital sectors. In this current climate, the inclusion of homeopathy of primary healthcare level globally can considerably reduce the burden in all these respects. For integration to occur, the following action points must be implemented in these areas of education, research, policies and regulation, collaboration between homeopaths and conventional doctors, which is absolutely vital, promotion, as mentioned there in the WHO level healthcare plans. So to conclude, with reference to inclusion of homeopathy in the male medical education, mainstream medical education, recognition by the medical establishment is the key factor, along with government support. Another major obstacle is the enormous lack of funding in respect to the research, education, and practice of homeopathy. Also, it has to be said that the financially driven pharmaceutical industry has unethically influenced the medical establishment to promote their products, thereby generating and perpetuating demand, and even going to the extent of negative propaganda against homeopathy. Much of the media, especially in Western countries, have also joined in this negativity to compound matters. A paradigm shift is needed in thinking. Firstly, and most importantly, by the current medical establishment. On a positive note, I see the future being a collaborative approach where conventional medicine, homeopathy, and other systems of medicine coexist and operate in harmony for the health and the well-being of all. I would like to leave you now by just showing some quotes on homeopathy by very eminent personalities in history. Thank you.
Thank you, Dr. Sima Malhotra. Thanks for showing us the ways that homeopathy could be useful in the field to treat patients. Now, at this moment, it was planned that Dr. Ram Manohar will be presenting some topics on research used to some unexpected problems, personal problems. His place will be replaced by Dr. Sani Anand. And I want to mention some topics about Vaidya Ram Manohar. He's a leader in the field of Ayurveda research for over 30 years and research director at Amrita School of Ayurveda in India. And his topic is integrating ancient traditions like Ayurveda into global healthcare through cutting-edge research. Thank you, Dr. Sani, again.
Thank you, Jorge. I will complete this session by replacing Dr. Ram Manohar in an array of giants in this field. Dr. Ram Manohar really stands out phenomenally as the one person who has introduced Ayurveda to the basic scientists, to the clinicians, particularly in the Western world. So that's why he was given this topic, integrating ancient traditions like Ayurveda into global healthcare. So let's look at Ayurveda in the Indian and global scenario. it's a dominant form of traditional medicine in India, but also has a legal status in this country, along with other systems of medicine like yoga, naturopathy, Unani, Siddha, Sova, Rigpa, and homeopathy, commonly known as Ayush. It is foremost amongst countries like Sri Lanka and Nepal in the practice of Ayurveda. And this complementary alternative medicine, CAM, is gaining visibility all over the world. Although, this CAM is transforming into complementary and integrative medicine, but still Ayurveda has not entered into this spectrum so much as traditional Chinese medicine or some of the other forms of medicines practiced elsewhere. So what about Ayurveda and integrative medicine? It is predominantly a standalone system in India and also in other countries. So integrative approaches, including Ayurveda, is still just in the early stages. It's in its infancy. But occasional practitioners have incorporated it into their practice. In India, it exists like all religions, all cultures, all systems of medicine coexist in a very healthy, balanced way, although somewhat lopsided by the resources that are spent on the Western style of medicine. This is our legacy from the British rule. But recently, the Niti Aayog has formulated the One Nation, One Health policy with a focus to integrate Ayurveda and all of these systems into the integrative domain, like traditional Chinese medicine is practiced in China. Could I have my slides? So what are the challenges? There are many challenges, many bottlenecks that come in the way of integration. These are mainly concerns about the safety of Ayurvedic medicines, about the authenticity of what the raw drugs are, of drug and herb interactions when they are used concomitantly. And there's a lack of understanding of mechanism of action of these Ayurvedic formulations. So the fact of the matter is, like, for example, haldi, or it's a very potent anti-inflammatory agent. It's been used for thousands of years in India, Thailand, and many other countries. But in the West, they tried to isolate curcumin, which is one of the active ingredients. But when you give curcumin by itself, it doesn't have the same anti-inflammatory effects. So Ayurveda incorporates multiple molecules in a holistic manner into the formulations that it has prepared. And these complexity of interventions not only include the active agent being used, like haldi or like a herb, but it's also multimodal. Multiple herbs are given, including changes in diet, in lifestyle, in body-mind approaches. It gives the whole person. That's the Ayurveda, and because that is the approach, it cannot be studied in randomized control trials where there is a one-size-fits-all kind of approach. So there is also a scarcity of high-quality research publications in this area. So can we go on to the next slide? So what are the challenges with the high-quality research? There is very limited funding, less than 5%. There's lack of rigorous training in research methodology. There is limited collaboration of specialists in modern science and Ayurveda. There are ethical challenges where, simply blinding cannot occur because the whole person is involved in lifestyle, in herbs, in diet, in their body, mind, the yoga, the breathing, the pranayama, all of those things go together in the Ayurvedic approach. So there are ethical challenges, and research methodologies have not yet been evolved to study these complex interventions that are available in Ayurveda or other. And in addition, there are laws and policies that seem to lopsidedly favor the Western approach rather than the more traditional approaches. So what factors do we need to consider? Ayurveda is a codified system of medicine spanning 10,000 years, or years innumerable, compared to Western medicine, which is barely 200 years old. There's rigorous updated documentation of its practices, but less than 10% of this literature has been converted into manuscripts. And even what is available in manuscripts has not been studied very critically or analyzed in a proper manner. So this ancient evidence, ancient medicine, which was based on trial, error, observation, and assimilation over thousands of years, is lying lost to us, lost to humanity. So what are those key factors? What should we do about this? We should take, normally what happens is, in Western medicine, scientists discover a molecule, then they apply that to tissues. Then that tissue is applied to animal models. And then finally, it comes to monkeys and humans and so on. So, however, there is so much information in Ayurveda that we have to reverse this pipeline of flow in so much going from the bedside to see why this is effective in various conditions. And so this Ayurvedic interventions have been used for centuries, but they cannot be fit into like a round peg into a square hole. We need real world clinical studies. We need pharmacoepidemiology and pharmacovigilance and reverse pharmacology, going from the bedside to the bench instead of the other way around. And these are all of the relevant ways in which we can accumulate some preliminary data for research in Ayurveda. We must acknowledge that Ayurvedic formulations are complex. They have multiple ingredients. The active molecules will not, finding those active molecules will not help. It's simply not the approach that should be. So the attention has to shift from single molecules to molecular combinatorics, or approaches like network pharmacology or polypharmacology need to evolve, where we look at synergy, antagonism, multiple targets from multiple ligands onto receptors and cells and so on. And that is the way we can advance this science. Where do we stand right now? Research publications in Ayurveda are minuscule. Even compared to traditional Chinese medicine, they're minuscule. There are 50,000 journals that are published each month. Each journal contains between 15 to 30 articles. And so you can imagine, in the totality of biomedical literature, Ayurveda is not even a nano drop in this whole. So you look at PubMed, there is very few, this is the most widely known literature database. And so much work needs to be done. There's need for research, rigorous research, and the right kind of research. Yet there are very few exemplary studies. So we have to cull this information from codified traditions. There's the traditional knowledge digital library that has been started by Government of India. There are other things like the Charaka Samhita, History of Indian Medical Literature, again, the Charaka Samhita and the Sushruta Samhita projects that are being launched, have been launched by various different universities. So clinical trials, there are randomized clinical trials that have been done and have shown, have been funded by National Institutes of Health where the whole system complex Ayurveda treatment was tested against placebo and blinded testing against methotrexate in the area of rheumatoid arthritis. These publications are relevant in advanced top-level journals, and even the most ardent critic of complementary medicine, Dr. Ezard Ernst, said that this should be the blueprint of studies. So what is that clinical trial? This was a trial that was performed by Dr. Ram Manohar. Ministry of Ayush funded this project in addition to various other agencies, and they tried this for rheumatoid arthritis. The results showed that the Ayurvedic treatment is beneficial in reducing the osteoarthritis in the knees. And as you can see on that, on the bottom right, there is this graph. This is a change in the pain score and mobility score that occurred over the space from baseline to 12 months. Whereas the dotted line shows the treatment with methotrexate and other immunity damaging drugs. The Ayurvedic treatment was much, much more effective with almost no side effects, whereas a number of the people, this research was published in Osteoarthritis and in the Cartilage Journal, and it won the ESIM Award for Excellence in Integrative Medicine Research. So how do we go from the bedside to the bench? There are various biology initiatives and other things that are happening in order to try and move this science more into the mainstream of biomedical science areas. So the way forward is we have a great understanding of what are the ground realities, challenges, other approaches, and how Ayurveda can be taken to the next level. We've learned from some successes and many failures, but the real world research that is needed to document this must follow rigorous scientific principles in terms of design. The models may be different, the randomized trials may be different, but the rigorous rigor in the scientific rigor should not be compromised. The bedside to bench approach, going from the clinic to the lab, the reverse pharmacology that needs to occur should be investigated, and thereby finding the mechanisms of action and launching comparative effectiveness trials against the standard of care for various things. So in conclusion, Dr. Ram Manohar said there are 3 T's: texts. What is there in these ancient texts that is still not available to us? What is tradition? What is prevalent in the practice of Ayurveda? We need to search for those experts and sit at their feet and get this knowledge and wisdom from them. And then testing. What are the right methods for testing and how we can move this evidence to become available? In a nutshell, this is the roadmap for integrating traditional systems of medicine like Ayurveda into the mainstream global healthcare systems. With this, namaste, and thank you on behalf of Dr. Ram Manohar.
Thank you so much for Dr. Manohar for this presentation where he shows the current situation of research of Ayurveda in India. And I think that Professor Sunny Anand not only is a professor at the University of Stanford, but he went also to be a professor of Ayurvedic research. Thanks. Thank you so much. Okay, now coming to the question and answer sessions, and we have received in advance one question from a group of students of medicine that we want to share, and I think if Dr. Kotechashi is available, thank you. If Kotechashi is available there, it's a proper question for him. They want to know what's the current situation of the practice of integrative medicine in India, because previously it was allowed and now perhaps it's not allowed in different parts of the country. And that's the question for future students. They want to know what could they do and what could they not practice.
Could you put up?
Yes, you are audible, Dr. Katisha. Do you understand the question, or may I repeat again?
Yes, actually, your voice is having echo. Probably Dr. Sunny was speaking, that mic is on, so there is echo is being generated. So I'm not able to understand what.
Now you hear me properly, or echo?
I am reading that those questions, and I will try to reply those questions. For example, Vinith, he has a question: can medical students also do research in Ayurveda? If so, what kind of topics would you suggest? Actually, in a holistic manner, I would like to answer this question that when we talk about or we think about Ayush research, it is widely misunderstood that Ayush research is only domain of Ayurveda or Ayush people. So if you want to do research in homeopathy, it is a domain of homeopathy. If you want to do research in Ayurveda, it is only Ayurveda people can do it or shall do it. It is not true. We are talking of science, and science should not be, paternal right of anybody. So I would request to expand our horizon. Everybody should think about, looking at the possibilities into research into herbal medicines or principles of Ayurveda. There are a lot of opportunities. Like Dr. Sunny Anand just have mentioned about these, two examples about study on rheumatoid arthritis and having comparisons of whole system approach of Ayurveda with methotrexate, or osteoarthritis and its effect on of Ayurveda intervention and yoga intervention in osteoarthritis. So there are a lot of such possibilities available to look at principles or drugs. And then
no connection with Dr. Katisha right now. We'll wait a few seconds, if not.
More of reductionist approach or holistic approach, So what we are supposed to look at, when we look at reductionist approach, we only talk about molecules and then further fine-tuning about looking at molecules. I would like to, put an example that when we eat, we have varieties of food. And these varieties of food, we never look at the interaction of, if we take like chapati with sabji, or we take chapati with dal. So, it looks very simple, but it's not that simple. When we talk about interaction of Ayurvedic drugs with modern medicine drug, or having adjuvant about Ayurveda. So the only thing is we need to work more and more, talk to each other, and then, and having more and more interaction, finding ways. Everybody should own the researches into the traditional medicine systems. So it's not only the traditional medicine people only can do this, because these are largely practitioners. They are not they are not experts in research. So we need to, sit together and then work collaboratively in a very, in a like consortium manner. Then we can deliver. This is one aspect. Then there is another question. Many medical drugs for the conditions that you have mentioned, and the treatment is effective and has a better prognosis. What are the advantages of homeopathy over allopathy? This is the question probably the expert of homeopathy can address. Then there's one more question: how do we break the barriers and misconceptions of treatment with allopathy and Ayurveda going hand in hand? I think I have tried to put this in my answer of the another question. Thank you so much.
Thank you so much, Dr. Katisha. Perhaps Dr. Malhotra could speak about the question about the advantages among homeopathy and modern medicine.
Yes, first of all, I think I may have made a slight error in my talk. I just wish to correct that. I might have said 25 years. Homeopathy has a history of 250 years. Yes, coming back to the advantages, yes. There are many more than I had time to mention in the talk, but another advantage really is in prevention. See, many of these chronic conditions can be prevented by the timely intervention with homeopathic remedies. In the homeopathic philosophy, we have different methods of prescribing, and one of these is called constitutional prescribing, whereby the whole person's mental characteristics, emotional states, physical symptoms, even their personality traits and physical description, all these things are taken into consideration, and they are given a constitutional remedy regularly, maybe once or twice a year, just to keep their immune system in a healthy state. So by, thereby preventing the onset of many conditions. So that's another area, and also the advantages I listed before anyway, economic advantages and, side effects are not there and so many.
Thank you, Dr. Sima Malhotra. We have one question also from the medical students for Dr. Nagendra. If you could mention some research studies about the advantages of the benefits of yoga for several diseases like cancer, burnout, immune diseases, so on. Please.
Too much of reflections. I cannot hear what exactly we have been talking. But as I see the question and answer thing, I found the answers already is given by our dear Rajeshji. Now, the main barrier for allopathy and Ayurveda going hand to hand is a lack of knowledge by the modern medical people about the grandeur and the contributions and the great depth that Ayurveda has. Unfortunately, the whole research in allopathic system has been geared with the aspect of effective, what Ram Manohar said rightly. Ayurveda and yoga, all these things look at man in a holistic perspective. They look at not only what is happening in a particular gene or a molecule, but it looks at all aspects of the human personality. When you take a particular medicine or give a particular intervention, we'll see what happens in the genes, in the autonomic nervous system, in the brain, in immune system. Not only that, what happens in the prana, what happens in the mind, what happens in the emotions, what happens in the whole system. As we call in Yoga Upanishads, we say that 5 layers, the gross body and the subtle body and the causal body. All these things have to be looked at. For that, what we have done is we have developed a wonderful research lab here. We track all these aspects in its grandeur. Therefore, we know what is happening. For example, if you take a bio well, we can know what is happening in the pranamaya in great detail. Which organ, which system, and how much is the change, how much is the imbalance, what is the normal data, all these things can be tracked. Just like when you take a blood test, you can take all the details. Similarly, we can find out what's happening in the pranamaya kosha. Similarly, in the manomaya kosha, whatever thing that's happening in the mind with all the psychological parameters, everything, we have a lab for these things. So similarly, what is the levels of different changes that are occurring at different levels can all be tracked today. Thanks to modern technology, we have this equipment which we have to use. And this is how we have to do that to see the total changes. Another important point Ram Manohar mentioned, which also agreed by all of us, is that this research methodology of double-blind studies and then RCT trials in general, without understanding the wholesome effects of Ayurveda, yoga, naturopathy, and Ayurveda systems, has to be kept. For example, when we started our research way back in 1970s and early 80s, we said that yoga, we told to the people, you think that's a black box, like a disease, as a particular drug. And we will use this. It contains asanas, we have pranayama, meditation, cyclic meditation, stress management, all these things as a lifestyle module. And that we did a RCT trial with comparison with the normal approach of the allopathic system. And we did the long-term follow-up for 54 months and published the papers in British Medical Journal. This is how we have to go in Ayurveda and these systems also. But to take essential component of one, it may not work. So I agree with Gita Krishnanji, Rajesh and also Ram Manohar that this is the major hurdle in these things. So this has to be looked into and worked on this thing. And as far as homeopathy is concerned, it's a fantastic system. The great advantage is that cost effectiveness, and we have been using that in large number of villages way back in 1970s, late 70s and early 80s, and in about 20,000 villages we have used this homeopathy, and the results have been very wonderful because it's very cost effective and it can take care of all the things. We've made a small package of the common ailments, normal infections, headache, the little fever, the cold and other things, and homeopathy works wonders. Also, it has done wonderful things which we have noticed in various very complicated diseases which are essentially NCDs in nature. Therefore, homeopathy and Ayurveda system has to be combined and has to be brought forth. But another aspect which I mentioned is there are 50,000 research papers as on today which are published in Index Journal about the Ayush. This is not known to people. Now, in the Ministry of Ayush, it has been put into the web, which should be used and brought to the notice of the people at large. This is not known to people. Even way back in 90, as I mentioned, there are 33,000 research papers that have been published in Index Journals, not in magazines and others. So there are enough evidence for this, but we have to pull out what is needed. Therefore, in AIMS Delhi, we have been able to integrate this in all the departments, bringing the yoga dimension into the whole thing, and then we have started. Also, Mantralaya also has been able to support this, and many Ayurveda things are going on. Therefore, integration is on the way, but it has to be spread in a big way, and Gita Krishnan also plays a very important role in bringing this integration. Thank you very much.
Thank you so much, Dr. Nagendra. One question for Dr. Gita Krishnan. There are some problems of language, there are other problems of vision, and there are other topics that are very hot topics for both allopathic or traditional medicine. And the question is related with vaccines. Which are the opinion of different traditional systems of medicine, particularly in the case of your knowledge about Ayurveda, about vaccinations? Because you know that sometimes for allopathic doctors, vaccines is the very tool that they could not renounce to it. And if the traditional system of medicine present, no, we are against vaccines, they began a lot of fight. What are your opinion about that, please? And these are very difficult and very important to discuss about vaccines.
Question. In fact, Ayurveda is, I can talk about Ayurveda because I cannot talk about other systems of medicine, but I think by looking at it from other systems of medicine also doesn't have much of a difference in my opinion. We are very pragmatic systems of medicine, like very pragmatic. What is useful for the patient is useful for the patient. What is not useful is not useful. So if something is useful and found to be socially acceptable, scientifically relevant during a particular period of time, when it's a particular period of time, I mean, it has developed, these sciences have developed at a time when people had just started, like, in other parts of the world, or in certain parts of the world, people have not even started wearing clothes. So, the times which had passed through in this through the science and its development is tremendous. It has always stuck to what is relevant in time and in according to the prevalent science. And the prevalent science says vaccines are important. So vaccines are very important. Vaccines should be taken. Vaccines should be followed. And I also come from a tradition which says, in some way or other, that we were the first to have identified how to vaccinate people in terms of smallpox. So I don't think that modern medicine can claim that. Chinese medicine is trying to make a claim. Ayurveda also has a claim on that, saying that we were the first to have started vaccinating people and having used that process of vaccination. So how can we, as Ayurvedic doctors, be ever against vaccination? Thank you.
Thank you so much, Dr. Gita Krishnan. There is one question for Dr. Sanyanan.
So this question has come from the audience. They say, allopathic is simply glorified Ayurvedic medicine, because many of the allopathic medicines, they take the active compounds from nature, like plants and so on. And you know, what is the opinion? I agree. I think, you know, the analogy that Dr. Geeta Krishnan gave was extremely relevant and pertinent to this, where he said that the Western medicine goes from structure to function, whereas traditional medicine goes from function to structure. And so I think people observed the function that was seen from the use of these ingredients, these herbs and other things, and then tried to see, you know, how what was the molecule. Unfortunately, because medicine has been, I should say, subjugated by the economic and by the profit-making capitalistic system. That's why a lot of the Ayurvedic medicines that are being used, but are not patented, you know, are adopted by these pharmaceutical companies and licensed and patented and, you know, used for profit making. There are people who were trying to, you know, patent turmeric. But what is normally found in nature, you cannot patent it. And yet there were several companies that tried to do that. That's why they came out with curcumin, and they tried to, you know, patent that, but it was really not effective. So I think this whole disconnect has to happen between an economic incentive and the practice of medicine. And traditional medical systems like Ayurveda, the Ayurvedic practitioners were highly respected. Their needs were taken care of. They did not need to live in a 7 or 10 bedroom house and not use, you know, 9 out of those 10 bedrooms, like Sadguru had pointed out. So it was a system that was disengaged from the economic, economic or fiduciaries kind of system. So that is really important. And I agree with you. I think many of the patented allopathic medicines have had their origins in Ayurveda or traditional Chinese medicine.
Thank you so much, Dr. Sani. Dr. Geeta.
Thank you. In fact, just to add to what you said, Dr. Sani, in fact, Ayurveda and traditional medicine and modern medicine are going to the same station, from one station, or some probably trying to take everyone to health. And they are actually like two different railway tracks. One is a meter gauge and the other one is a broad gauge. You know, like probably modern medicine is broad gauge because it goes faster, but it cannot stop in all stops. Whereas a meter gauge, being slow, till takes you there and it goes through every single station. And, you know, you can look at more detail in a meter gauge than in a broad gauge. You can maybe change it to high speed, like, you know, a train and a broad gauge right now, because we are going into that age. But still, a high speed train going between Delhi and, you know, Mumbai and Ahmedabad cannot stop in every stop. It has only few areas where it can stop, whereas a slower train can take more people and can definitely stop at every single place and take you everywhere you want to go. Thank you.
Seeing the smiles in the audience, I think that you have put a proper metaphor. Thank you so much.
Yeah, I have another metaphor.
Okay.
You know, to get from Mumbai to Ahmedabad, is that Ahmedabad? Yeah, you can either take a straight road or you can take a curved road, the scenic route, like they say. But the straight road on the highway does not create a skilled driver. It is a cookie cutter approach, which is what is allopathic medicine. But if you take the scenic route, you not only enjoy so much more of everything that's along the way, but you also create skillful drivers who can navigate through difficult conditions like the pandemic. And that is why I think, these traditional systems of medicine have an enormous wealth which needs to be brought to bear on the human condition in the world today.
We have the last, thank you so much again. We have the last question for Dr. Sima Malhotra, and later we will ask Dr. Rajesh Kotecha your last thoughts about this topic. The question is, the principle of homeopathy are like yours like. However, from what I understood from your presentation, the principle is entirely that like yours like, since there is some level of intervention. So, is homeopathy another type of allopathy?
Perhaps it's best by answering this question by just giving you an example in everyday life. For example, we know this high-powered, stressful jobs that many people have these days. They're drinking maybe 8 to 10 cups of coffee a day. And we see the outcome of having that amount of coffee over several months can often result in the person becoming on edge all the time, very jittery, can cause insomnia. This is very common. I have treated patients like this myself. And so normally you would, resort to the normal anxiolytic type of drugs, to calm the patient down, make them a bit, calmer and so on. But with homeopathy, with this particular case, when you know that this is possibly the cause, we would give coffea cruda, which is a homeopathic remedy made from coffee bean. And I've used this myself, not on myself, on a patient, to wonderful effect, where it is, again, very, very highly diluted and probably practically not there. If you use like a 30C, 200C potency, there's no chemical substance there of the coffee. Yet, it works. The patient he becomes calmer, is normal, he feels better, able to sleep, and so on. So here, this is what I mean by the principle of like cures like. The cause was excessive coffee, material dose, material level, and the remedy, the treatment for it is using coffee at that highly potentized level, which is the energetic level, which is basically showing us that we as human beings are really energy at the end of the day. If we can bring that energy into a harmonious state, and in fact, it is that energy which differentiates a dead body, a lifeless person, from somebody who's living. When that energy goes, which is prana, which in homeopathy is called vital force, when that goes, then actually, the body is dead. It's not just, the heart stops functioning, but why? Why? Because the prana has gone, the vital force is gone. So our remedies are aimed at that in homeopathy, at going to the crux, really. Go for the vital force. It's not appropriate in all situations, because sometimes you do have situations where you need to, for a speedier action, need to work on the body level. But that's not to say that with homeopathy you can have tremendous quick results as well. I've had a recent case where someone was extremely restless, and they were leg on the bed, leg off the bed, going like this, fear of death, and just couldn't settle. And thought, what to do now? This literally, you could see that going on. And I gave the remedy aconite in high potency, 1M, extreme dilution. The patient was just all these symptoms of restlessness and confusion, anxiety, everything just within 5 minutes. Became much better. So it can work quickly as well. Yeah, you have to see, I would say, all the systems have their their place in different circumstances, different situations. So.
Thank you so much, Dr. Sima. Dr. Kotejaji, please, your final thoughts about this integration of medicines, please.
Thank you, Dr. Bera. As a chairperson, you are so efficient that you were able to finish everything in time. And I will finish into those available time. First of all, it is these deliberations, these talks, and these discussions are quite enriching for me also in person. So thank you for providing this opportunity. Based on this, if we have a lot of take-home message, first is that yes, quite of the activity of integrating the knowledge, traditional knowledge of health is being integrated into mainstream medical education, research, public health, and clinical practice. It is happening. I would like to, also mention that there is last question is about that integrative integration means cross practice. I would say no, it is not that true. It is not that simple also. Integration means that the best part of the different systems should be brought into the mainstream practice for the benefit of the patient. And Dr. Gita Krishnan in his presentation have provided some good examples also. In his presentation, probably due to lack of time, he did not mention another wonderful example that I know because of my communication with him, that he has used this triphala paste with honey on the a very severe stomatitis because of a patient having tracheostomy and having exposure to a lot of antibiotics. So there was a secondary infection of fungi, and then this worked, and no antifungal drug were working where the triphala and this honey worked. And then in laboratory, they found that it actually grows. It actually helped the fungi to grow. So how fungi were happily living there? So these are the questions, and the answer lies into the real science experiments and looking for the mechanics, how it works. There is an area of new area of understanding of health mechanics is microbiomes, and through microbiome we understand a lot of these principles of polyherbal therapy or practices of Ayurveda and other traditional systems of medicine, how it works. For example, recently we found that Parkinson's has this gut-brain axis, and this gut-brain axis actually has provided a lot of understanding of how Ayurvedic practitioners do Basti Chikitsa into Parkinson's and get great improvement into the patients. The another aspect is cost effectiveness. Dr. Sima ji have mentioned that there is a lack of budgetary allocations and there is a lack of finances, and actually, I would suggest that look at this perspective, that these therapeutics are so simple, not non-expensive, actually. Like, for example, in pandemic, Ayush Ministry with the support of a lot of different universities, national institutes, research laboratories did at least 137 studies, and all of these studies were different designs. It was not only clinical studies of randomized controlled trials, but it was large-scale observational studies, prophylactic studies, mechanic studies, preclinical studies, in vivo, in vitro studies, even docking studies, and a lot of such studies. Like understanding what is happening, and then we're able to also repurpose a couple of medicines like Ayush 64 and Kabasura Kudinir. So I would like to mention this about the Ayush 64. It is a repurposed medicine originally invented by CCRS for malaria. Then later it was found effective in inflammatory lung disorders, ILD, and then it was repurposed for COVID, and then it was found through several studies that it is effective for mild to moderate and or asymptomatic COVID patients. And then the cost is for 3 weeks of sub-medicine is only 250 rupee. So nobody could believe that in 250 rupee how COVID can be managed, when whereas there are thousands or lakhs of rupees were required for the COVID patients. So that actually is a very unique thing that these therapeutics do not require a lot of funds. So that is good for the patients, but it is counterproductive also, because since it do not have money, the big people do not get attracted. There should be illuminization, there should be big hospitals, there should be very big impressive infrastructure to be qualified as a hospital. So that is a counterproductive thing also. So we need to look at that perspective, because people are largely attracted with this large infrastructure and then illuminated things and lot of expenses, and they should be educated, they should be properly conveyed that these simple things also work almost similarly or even better. Then another aspect is all roads goes to the Satya. So different roads we can take, meter gauge train, or we can get zigzag roads. Everything takes us to the Satya, or ultimate truth. So it is fine, in a democratic setup, like we are in a democracy, and then human minds are different. So a lot of things depends upon patient, what they want, and accordingly they should be provided the solution. And last thing about my concluding remarks is that present scientific understanding actually there is limited scope of understanding these sciences. So this limited scope we have to accept, and within that scope, whatever we understand, we should try to evolve more and more, and maybe we can understand better in coming days. So it is a journey, and we have to continue this journey in a very dynamic way. Thank you so much.
Thank you so much, Dr. Kotecha-ji, for your final remarks. Thank you, Dr. Sima Malhotra. Thank you, Dr. Gita Krishnan. Thank you, Dr. Nagendra. Thank you, Dr. Kotecha-ji. Thank you also, Dr. Ramanohar. Just one final thought. The people who need the integration of medicine are the people. These are the real force. And remember that all of us will be patients at one moment of our lives. Our body and our mind are here in this earth to decay and to disappear. And we need the integration of medicine. How this integration will be carried out, it depends on the language and the interests of both modern medicine and traditional medicine. But the people we are the people that we need the integration of medicine, and that is our work for the future. Thank you so much. Thank you for the university, Satya Sai University of Human Excellence. Thank you, Sadguru. Thank you to all of you. Thank you, Simon.
Thank you, session chair, panelists and delegates of the session. We will now have a break for 15 minutes and shall reconvene at 10:20 for session 4. Thank you.
I'm going to share with you about the leading causes of life.
Good morning. Welcome to this session 4 of the International Conference on the Future of Medical Education. While the focus of medical education should continue ensuring quality standardization and adopting an integrated approach to care, one cannot miss the critical role of training in the social, psychological, emotional, cultural, and spiritual aspects of medical care. With the increasing burden, global dialogue on creating diverse and inclusive models focused on an integrated rural approach and an equitable medical education model is the need of an hour. This session shall focus on these challenges and the use of technology to expand accessibility and affordability of care to the underserved populations. The co-chairs of this session are Dr. Heeramalini Seshadri, an alumna of the Christian Medical College, Vellore, and serves as a rheumatologist at the Sri Sathya Sai Sarla Memorial Hospital at Sathya Sai Grama, Mudanhalli. Professor Navakanta Bhatt, a PhD from Stanford University, and currently the Dean, Division of Interdisciplinary Sciences and Professor, Center for Nanosciences and Engineering, Indian Institute of Sciences, Bangalore. We now request the co-chairs to kindly commence the session.
Thank you, Soumya. Namaste, everyone. The best, they say, is always reserved for the last, and now here we are at the final last session of this medical conference on the future of medical education. All the speakers have new ideas to share and out-of-the-box solutions. So it's bound to be a very interesting session, particularly for the medical students. The first talk dwells on a paradigm shift. Junior doctors and medical students will agree that they have been lectured on ad nauseum about the causes of diseases, the causes of death. How about the causes of life and what promotes health? To talk about this, we have Professor Dr. Teresa Cutts from the United States of America. She teaches in a medical college in North Carolina, is part of medical education think tank. She helps formulate policy in social and health matters and is a champion for the equity of healthcare for the vulnerable and disadvantaged. She especially made this talk for us here today, so let us listen to her. Dr. Teresa Cutts.
Good morning, everybody. My name is Teresa Cutts. I'm going to share with you about the leading causes of life and how we used it in the medical setting, changing the paradigm and practices. I shared with you that I have no conflicts of interest to disclose, and I'm going to quickly go through the 5 leading causes of life that were developed by my life partner and my husband, Reverend Dr. Gary Gunderson, and how we've used that in terms of health system, medical center orientation, leadership training, in an integrative medicine primary care practice that we worked in, and with an executive physical model of cohorts called the Life of Leaders. So the leading causes of life is based on idea that came from Gary Gunderson. He actually wrote a book about this in 2009 with Larry Prey, his colleague. But he was based early on in the day. He was based in Atlanta, and he worked at the Interfaith Health Program at the Carter Center and then Rollins School of Public Health at Emory. So he was exposed to a lot of the CDC folks. And as you know, their focus is on the leading causes of death or what kills you. And we know that that's something that's really been going on a lot here. We think about it a lot during COVID-19. But he really wanted something, a new paradigm to kind of counter what kills you, and think about instead what gives you life. And so this paradigm is very almost the opposite of traditional sort of pathology-based allopathic medicine. And it aligns very beautifully with many other different fields: social complexity theory, positive deviance, positive psychology, flourishing, and resiliency models. And we don't have much time to go into the theory and the practice, but it aligns beautifully with many of those areas. The first leading cause of life is connection, and it's pretty face valid that all humans need to be connected or we won't survive. Connection via touch, intimate relationships, emotional attachments, shared values, memberships, networks, movements, beliefs. That's really crucial for us from the cradle to the grave. We all know the Bowlby orphan study where babies that were not picked up and touched did not thrive and some didn't even survive. We know some of the long-term studies in community, the Rosetta County study of tight-knit Italian families, that even though they ate diets high in fat and butter and smoked and had unhealthy lifestyles in some ways, because they were so close-knit, they had 1/6 incidence of cardiac disease and heart disease. And then we all are familiar with the Alameda County study where we found that people that were connected not only have better quality of life and mood, but also it impacts their mortality in a positive way. The second cause of life is coherence, and it's really what meaning we make of our life. How do we make sense of our lives, our ever unfolding story in our lives? Our meaning system is conscious web of belief, rituals, and memberships, but it also includes our unconscious thought patterns, which is a big part of what drives us as well. But I think coherence aligns beautifully in terms of science with post-traumatic growth work, people that have gone through trauma but come out on the other side much stronger. You are probably familiar with the research that's been done with even children after the Oakland earthquake that had experienced trauma or bad experiences, were able over time to change their story. The story became positive, more of a hero's story, and good things were gleaned from that. And then James Pennebaker's research, I think, about sharing your deepest, darkest secret, whether it was to a tape recorder or to a human or through journaling, impacted all people's vital health metrics, whether it's blood pressure, heart rate, skin conductance, immune system functioning in a really positive way, both acutely and months after people shared about what was going on with them. Agency is the third leading cause of life, and it really is the ability to act and do. And it aligns most beautifully with the Albert Bandura's work in terms of self-efficacy that came out in the 70s. And of course, decades of work have built on his original formulations, including our colleague Doug Omen's work out of Berkeley on spiritual self-efficacy in the early 2000s. But when we think about agency, we often see that most potently in the lives of people that don't have much traditional power, resources, or control, including HIV and AIDS orphans in sub-Saharan Africa. These are kids that lost their parents. They were stigmatized by others, but many of them had a lot of agency and were able to survive. Prisoners of war who would find creative ways to gather up scraps of trash in their cell block and communicate with other people or engage themselves intellectually or emotionally over time. And then mothers of malnourished children in Vietnam during the early work that was done with positive deviancy in terms of grassroots mothers that were able to figure out what are the things that are happening that my baby's not malnourished, and how do we figure out how to codify those behaviors and then scale that up by teaching other mothers so that we can save lives. The fourth cause of life is intergenerativity or blessing. And we think of that as webs of life flowing across generations. We often think of that as our ancestors do to our children. But I also think it's just a bi-directional dose of love that flows from just person to person. We can bless or curse a person in any interaction. And certainly at a community level, we can do that. And I think our communities are in need of healing right now. And I think the field of science that aligns most closely with this cause is psychoneuroimmunology, or the study of how emotions, attitudes, and beliefs impact our immune system functioning. The question to ask yourself about this individually is, for whom are you a blessing, or do you provide positive energy, love, and compassion, and who offers those factors to you? Then the last leading cause of life is hope. It draws us together toward life in the future. Some researchers call hope a memory of the future, that it's that vision of what could be that guides humans as memories of the past guide other animals. It's the substance of that not yet seen. And I really think it's the antidote to fear. And when I think about medicine, many of you know the study of chemotherapy drug that had the acronym EPOH. They did a clinical trial. And then they did another trial and they renamed it HOPE. And that chemotherapy drug in that second trial had such better outcomes. Hope. People got a drug called Hope. And we can see that positive placebo effect right there. So when we think about the causes too, I think it's important to note that they work together as an ensemble and they feed one another. And as we talk about a survey that we developed for our primary care work, these connections, all the different causes are really very redundant and they're overlapping. They are not independent domains, but it was really developed, the framework was developed, the idea was developed to focus on what you have, your strength or your asset, instead of thinking about what causes you lack. And I know this is a very quick review of the 5 causes of life, but go to the original book or go to GaryGunderson.net for information on Gary's website, or the Leading Causes of Life Initiative, which is run by Dr. Jim Cochran and includes an international group of fellows that try to engage this framework in their lives and their work, whether it's economics, medicine, education, healthcare, et cetera. And that's found at leadingcauses.com. So do look into that more if you're interested in more about the theory and practice. But how have we implemented the Leading Causes of Life framework in medical settings? The first thing that we did at Methodist Labanner Healthcare in Memphis was that we provided a 30-minute presentation on the 5 causes of life to all new employees. And they found that very refreshing in a place that made its money off of people that were ill. And we also provided and developed a much more in-depth training for the top 500 people, leaders at the medical center, so that they could begin to try to use that framework in their work. And a lot of interesting things happened as a result of that. One manager worked with people that were tasked with calling folks that had medical debt, people that had been patients and had not paid their bills. And that was usually a very unpleasant interaction for both parties, the person calling and the person being called. And so she began to teach her staff how to use the causes in a positive way to make those interactions much more palatable to both parties. We also, on behalf of the hospital, provided 2-day workshops on leading causes of life to the United Methodist clergy across 3 states, because we were owned by those clergy conferences. And we found both in the hospital and in the clergy conferences that using the LCL language and ideas and inserting that into the culture was really an intervention unto itself, made people think about things in a more positive way. The second use was I was able to, with the Church Health Center and other people, to develop a spiritually based integrative medicine primary care practice in Memphis called Harbor of Health. And as we started up the practice, I'm a clinical health psychologist, so I worked with them. We use traditional health risk appraisals, but they're pretty much pathology based. So we developed short leading causes of life surveys that we piloted with 102 patients at Harbor of Health. And then we incorporated their findings into the care plans. For this sample, many people responded very positively to the leading causes of life concept and said that really expanded the way they thought about their health to a much broader view. I often think of that as something that came out of a World Council of Churches consultation in 2007 in your beautiful country at CMC Velour, the biopsychosocial spiritual health concept. And for these patients who were younger, 38.4 mean years of age, and more secular, what we call in the States nuns, N-O-N-E-S's, that did not adhere to traditional structured faith kind of communities. They had generally lower scores on connection and agency. And we did find a strong correlation between low coherence and agency scores and some of those stress-related types of illnesses, headaches, GI disorders, substance use disorder, depression, stress, and musculoskeletal pain, as self-reported on HRAs. The question that the patients really liked and found refreshing was, what's right with you? And Dr. Susan Nelson and I would ask that and pose that to folks as they came in. Another use of the leading causes of life framework in medicine was how we developed an executive physical model, a cohort model, where we bring in people up to 12 people at a time, called the Life of Leaders. And we did this with the Church Health Center. We conducted it for about 130 executives, foundation and hospital presidents, magazine editors, as well as bishops and district superintendents and other clergy leaders for the United Methodist Church, particularly here in North Carolina, and also the Reformed Church of America. The framework was used to focus on how life is a journey, not an event, and health issues occur developmentally across a lifespan. And it really was an adjunct to usual primary care. This was something that was sort of a special event that would be added on about every 3 years to reset or revitalize people, particularly at certain developmental career milestones, such as retirement or moving to a new job, et cetera. And we intentionally made the context of these executive physicals, we hosted them at a safety net clinic, the Church Health Center and Wellness Center for the underserved, because we wanted these affluent folks that had lots of power to interact with the least of these in the setting. So we did publish an article about the Life of Leaders process. You can see that in the Journal of Religion and Health. You can see that reference below, but I'll share a little bit about it. It's team-based. We had a medical provider, a life practitioner, and that was a behavioral health person, but we didn't call it mental health or behavioral health because it was asset and strength-based, nutritionist, and then a physical therapist / exercise coach, and other providers as desired. It was a 2.5-day process, so people could relax into the space. We had group music, meals, fellowship, meditation from local artists. In Memphis, it was often blues singers. And then concierge, it was concierge. It was tailored to the individual needs and wishes for specialty consults, including sleep and pain management, or treatments which included massage, acupuncture, acupressure, Pilates, aromatherapy, and others. But we gave people a lot of extra time. They had 90 minutes with the doc the first day, 90 minutes with the life practitioner and other providers on that assessment day. Day 2 was a report back with the provider, medical provider and life practitioner, which took 1.5 hours. So people had the time to relax and to ask questions and to really have a dialogue. And it was also based on extensive pre-work. We had them complete a short Myers-Briggs, a values and action strength survey from Positive Psychology, leading causes of life survey, and the Your Health Journey narrative assessment. The Your Health Journey narrative questions are here, listed here, and I won't go through these, but we kind of see this as the antithesis of a traditional kind of boring history and physical, because we delve into who that person is, particularly across their lifespan and what they're passionate about and what drains their spirit. But also thinking about family history concerns. How many of you know the case of people that, particularly maybe males, they wake up one day and they've never had a first thought about heart condition or anything like that, but they wake up and they realize, oh, I'm 54 now, and this is the age that my father died abruptly of a heart attack with no family history. So we really took the time to delve into that and build that into the process. And beyond Life of Leaders, we also did clergy health and leading causes of life. We used that same survey that we used in the primary care setting with about over 400 United Methodist clergy. And interestingly, they had lower scores on coherence. We said, well, hey, maybe that's their day job. And if their day job is helping other people know meaning in life, maybe they get tired of that or they're burnt out. But they had high scores on blessing and connection, mixed scores on hope. They didn't see much relationship between their community and health. And they liked the positive framework, particularly clergy that were struggling with burnout. They felt there was more time to really needed to dig into that dialogue. And interesting with clergy, they almost always quickly moved from talking about their individual health to congregational strengths. And so the LCL survey for congregations was developed in relationship to that. So I'm going to wrap up now with a quote from a book by Dr. James Lynch about the medical consequences of loneliness. And this quote kind of sums up for me one of the leading causes of life that I like a lot, connection. And that quote is, the mandate to love your neighbor as you love yourself is not just a moral mandate. It's a physiological mandate. Caring is biological. One thing you get from caring for others is that you're not lonely. The more connected to life, the healthier you are. So I want to thank you all for your time and for being with me today. And I hope that learning a little bit about the leading causes of life framework and how it might be used in medicine and medical education is really important to you. So thank you for your time and for being a great leader in this work. Namaste. Bye-bye.
A very, very rapidly paced talk it was, but a real eye-opener. So our very connectedness to one another can make us healthy and can heal our patients. So can hope. Hope can heal even better than medicines. That's why we need to do all our drug trials double blind. So These leading causes of life and health need to be taught in medical colleges and not just leading causes of morbidity and mortality. Our next speaker brings good news for medical students. Medical education, postgraduate, is all set to move away from urban clusters into the hinterland, into the more rural and underprivileged areas. And we have a very distinguished speaker here. He is a renowned surgeon at the Maulana Azad Medical College, Delhi, Dr. Pavanindra Lal, and he is the president and executive director of the National Board of Examinations in Medical Sciences for all of India. Dr. Lal.
So very good morning here, and really thankful to the organizers and in particular Professor Anand for this very kind invitation. Very warm greetings to all of you, chairpersons, esteemed faculty members, delegates, students, and all who are present here and on the online mode. I bring greetings from my two institutions with which I'm connected, the National Board of Examinations in Medical Sciences and the Maulana Azad Medical College. And the topic that I would like to cover this morning is how we are trying to create opportunities for medical education for better healthcare delivery in rurally and socially disadvantaged areas. For the first, I would like to, I think this is not connected. Yeah. Just wanted to tell who are we as National Board. We are an autonomous organization of the Ministry of Health and Family Welfares, and we under the Government of India, and we provide uniform standards for training, evaluation and assessment. We conduct postgraduate and postdoctoral entry and exit examination. We administer courses which are at postgraduate level, postdoctoral level, and we now have our presence in more than 800 institutions across 80 disciplines. And currently, around 11,000 students across the diploma courses, doctorate courses, and fellowship courses are enrolled in the entire country. The National Board covers the institutions which are not covered under the medical colleges, which come under the National Medical Commission. So this is one difference that I would like to tell everyone about. And we have a plethora of tests that we are very famous in doing. We conduct the National NEET postgraduate examination, the dental examination, the super specialty examination, and then various other licentiate examinations, including the foreign medical graduates examination, and our own courses that we run in our institutions. We run the exit examinations for all of these courses. So we are a very strong examination body. And the reason why the National Board has been recognized in the last few years is because of this ability to have a single body in the entire country, to have uniform examinations at the same time without any variance or variability in the standards and in the execution of the examination. The strengths of the National Board come in ways of conducting an efficient examination each time and every time. There is a high grade of integrity that is given to our examinations, and there are strict processes that are involved so that we do not have any kind of leakages or blames. And it is for this reason that we have now evolved to conduct the examinations on a computer-based model. So most and almost nearly all of our entrance examinations are on a computer-based test, where the candidate comes onto the hall and the questions are answered on the console itself, and the examination paper is released from the National Board after all the candidates in the country are seated, and the paper is released online from the National Board with several layers of encryption. So it's with that level of integrity that the government has entrusted this very important responsibility to us. And you can see here, I've given you this chart just not to show, but how the numbers have increased. And I would like you to see only the last bar on the right-hand side. In the last examination, which we have just conducted in the month of September, almost 1,77,000 students sat for this examination, which has about 45,000 seats. Just to bring you in touch with the number of students that we have 85,000 MBBS seats in the country. And for those 85,000 or 90,000 seats, 18 lakh students appear for the examination. So that is the first statistics that I would like you to remember. Then from these 90,000 students that are there in the MBBS courses, 45,000 are postgraduate seats for which these candidates will be applying. And it becomes double the number because there are previous year's candidates also who are interested to take the exam. And then the third level, which is the super specialty, there are only 6,000 seats. So for the 45,000 candidates who are exiting the postgraduate exam, we have got 6,000 seats, but not everyone is interested. Only about 20,000 people take this exam for the 6,000 super specialty seats. So that is the way the mathematics goes. And in the last few years, the National Board has concentrated a lot in taking the courses to the periphery. The National Medical Commission, which is the erstwhile Medical Council of India, took a very conscious decision of stopping the diploma courses in the entire country. Now, it was not because the diploma courses were a bad course. It's a 2-year course as compared to a 3-year degree course. The reason they stopped the diploma was because diploma holders cannot be teachers in medical colleges. So they said, why do you do a course which does not give us teachers? We need teachers to start new medical colleges. So they scrapped the diploma course by converting it into a degree course by adding 1 more year. So suddenly the diploma space became extinct. And the government then approached the National Board last year, and I was there at the time when this happened. And I was asked whether we will be able to execute the implementation of diploma courses. Well, this was a very, very new thing. And we said, if this has to happen, it must reach the peripheries of the country in the form of our district hospitals. And so I'm very pleased to say that in the very first year, last year, we have been able to execute this. And this year, the exam that you just saw, in which we have declared the results, about 1,800 new diploma seats are being added. And this will be used in serving the district hospitals of the country. We have made further inroads by starting OSCE-based examinations in the times of COVID. You can imagine the country went into a lockdown phase, and a national body like us was expected to take examinations in the entire country. So we devised a unique, objective, structured clinical examination, and we executed it in the subjects where there are large number of students. And using this modality, we were able to evaluate about 12,000 students at the same level and with a great bit of standard, so that these doctors can qualify and start service in the community. We have started an e-logbook, an electronic logbook system, and we have started thesis, which is on a PDF format, again, and a facility which in the peripheries where people find it very hard to make hard copies, it will go a long way in preventing them from the limitations in which they are located. We also use the COVID time as an opportunity to start our classes in the webinar mode. And using the online platform, we have now started teaching all our students, the 35,000 odd students in the country, through this online mode. Now, the nomenclature, I just wanted to say, we have 3 levels of qualifications. We have a 3-year course, which is a diplomate of the National Board. We have a super specialty course, which is known as a doctorate of the National Board. We have post-diplomate or post-doctorate fellowship programs, which are known as the Fellowship of the National Board. So to distinguish the super specialty people from the basic specialty, we have converted that name from diplomate to doctorate. That's a change. And for the fellowship program, to say the level, we have made it FNB or a fellowship at post graduate level, or a postdoctoral to say it is a postdoctoral fellowship. These are the 8 subjects in which we have been able to launch the diploma courses in the periphery of the country through this opportunity given to us by the Ministry of Health and Family Welfare. And the eligibility is a post-MBBS student. Course duration is 2 years. Entrance is through the National NEET PG entrance examination. There is no requirement of thesis. That's the wonderful thing about diploma. And so the teachers who are present in the district hospitals or in smaller private hospitals, they are able to train the clinicians by giving them the art and science of clinical work. Now, the important initiative about diploma, ladies and gentlemen, you would like to see 60 to 70% of our population is treated at district hospitals. And it has been 75 years since independence today that we have not been able to reach the residency program to the interiors of the country. So this is a landmark change where around the clock resident work will be available for our district hospital patients. And in the bargain, the doctors would be trained in the specialties in which they are located. I'm not expecting you to read this slide, but just to show that 1,800 seats have been added in these various 8 subjects, but only 15 states have applied for this in the first year. So there is a hesitancy, there is a latency for the systems to wake up. Even when there is an opportunity to be given by the government, everyone is not ready to grab it. So we are trying to push various other state governments. In fact, you can see Bihar, which has got a lot of need for doctors to go into the periphery, has applied for only 2 seats, whereas there are some states like West Bengal or Rajasthan, they have taken 400 plus seats in this very first year. These new diploma courses are being added. We are trying to debate on 3 new diplomas. Ladies and gentlemen and esteemed faculty members, there has been a diploma in orthopedics, but it has not yet been implemented under our patronage. But we have planned 2 new diplomas, diploma in medicine and diploma in surgery. And we wanted to see why not utilize the medicine and surgery departments in the peripheries of our district hospitals to train our students in medicine and surgery as well. In the first year of its implementation, these 3 programs have been put on hold to see the success of the other 8 which we have launched in the first year, which are well-established diplomas. And only then, after much deliberation and planning, would we like to bring in these new diplomas. But the question is, or a controversy that is always asked is, we should not be giving diplomas in a manner that they are misused or they are not validated properly. So we are trying to make mechanism where these newer diplomas get that sanctity without being misused. The NBE program and the district hospitals are committed to serve the population attending the district hospitals. And we have got a rotational program also, which allows these students to go into the medical colleges and serve as a residency program. And the government is trying to make a 3-month rotation compulsory in all the district hospitals from now onwards for our postgraduates from every medical college. So 3 months of their training will be in the peripheries from now on. And I think that in combination with our diploma will be a big boost to serve the peripheral regions, which are underserved regions in the country. We have encouraged the governments to have reservation for in-service candidates. You are aware that there are MBBS doctors who are in service who would like to upgrade themselves. We have ensured that 50% of the seats in the diplomas categories and in the DNB categories are reserved for in-service quota from the state itself, so that the doctors working in their healthcare system can upgrade themselves into a postgraduate qualification. And aligned with the same, we have the sponsored seats scheme, where the state governments can sponsor their service candidates, serving doctors, into the national board accredited institutions within the state and outside the state. It's very interesting. The state governments can send people within the state or outside the state to our institutions at the cost of the state government to serve in and get trained in that postgraduate degree and come back and serve their own people, so that the people who are with the basic qualification of MBBS can upgrade themselves to a postgraduate qualification. So in conclusion, ladies and gentlemen, chairpersons, our new outreach towards peripheral training is aimed at adding about 1,800 plus diploma seats in the current year, with the round-the-clock residency system care, which is attended by a huge majority of our population. I think this will be a game-changing decision since independence. For career progression, we have a secondary DNB program, so the diploma holders can upgrade themselves into a full-fledged degree after completing their diploma, which is another 2 years. And this will aim to increase the penetration of the diploma courses, and we have newer courses that are planned also, and we want to continue the national webinar courses, even if the COVID subsides, which we pray and hope it does. We will continue the national webinar classes, because that is the new thing that we have initiated. So I think with all these, we will be able to enhance the service to the peripheral areas in the country. Thank you very much for this invitation and for your patient listening.
Thank you, Dr. Pavadindra Lal, for that fantastic exposition of what National Board of Examination has been doing, and in particular, taking the medical education, postgraduate education to the rural areas and the hinterlands of the country. So we have concluded 2 talks. The first one, as you recognize, was more on spiritual aspects, connectedness, which is very important for healing. You know, it really depends on the belief system. And the second one was in the context of medical education, right? How do we really train? And that brings us to the third vector, which is also extremely important, and that is of technology. So the next talk is by Dr. Bipin Nair, who is professor, the School of Biotechnology, and also the Dean at Amrita University, Faculty of Sciences. Unfortunately, he is not able to be with us today. So in his place, Dr. Satish Babu will make this presentation on cost-effective application of cutting-edge biotechnology in healthcare. Since we are running a little late behind the schedule, I request Dr. Satish Babu to bring us back on the schedule. Thank you. Over to you.
Thank you, Prof. Navkant Bhatt, and thank you for the introducing me, not as Dr. Nair. You all know I am Dr. Satish Babu. The only reason or only minimal qualification I have to talk on behalf of Dr. Bipin Nair is he has put a lot of slides which is diabetes related topic or diabetes related discussion slides, and our course chairman rightly caught me yesterday and said you should do this talk. So that's why I'm here. And in fact, let me put the talk also into perspective. There are a lot of university graduates here, and the whole idea of this conference is one of the core objective is to how to bridge that gap between haves and have not in healthcare, and technology comes in forefront, and especially post-COVID, during COVID, lot of innovations, as the previous speaker also mentioned, there are a lot of inventions happening, and I encourage and look forward our universities, such as University for Human Excellence, also entering into this domain, and that's the whole point of putting Professor Naukant, but also as a chairman to this topic. In fact, when I called, he said it's more to do with social aspect of healthcare. I said, sir, it's to bridge that social aspect, we need the technology and innovation. So going straight to the topic now. So as I said, this slide probably made me to be here. So that diabetes is a huge problem. It's growing exponentially every year, and quite staggering numbers. And as our lifestyle change, diabetes is becoming more and more common. So it's becoming a common man's problem as well. I mean, not a rich man's problem anymore. And in India, diabetes occurs quite early, quite in young age. So there is exponential cost to this, to the individual, family, and the nation. So we need very innovative, in-house, means to say, Indianized inventions to take care of this chronic disease. It's a lifelong disease, so you need, and it's a everyday disease. You eat, your sugars go up. So you don't move around, you don't exercise, your sugar goes up. So it has to be continuously monitored and continuously looked after. So insulin, you all know, insulin comes in the forefront of diabetes management, and the best insulin delivery system is insulin pump, because it mimics the pancreatic secretion. It can be given at small amounts with the continuous glucose monitoring. So pumps play important role. And how much a pump costs? Somewhere around 3 to 5 lakh. And there are variables, that is consumables, which costs around 10 to 15,000 a month. So these pumps I'm talking when they're imported. When you talk about indigenous, the cost comes down, and that's what Dr. Bipin Nair and the team did it in Amruta. They've come out with the Amruta insulin pump, and the animal trials were quite good. They have applied for patency, and then they've moved to glucometers as well. And again, glucometers are quite expensive, especially the strips, because you need to use every day multiple times. And that also they have come out with a prototype, and as WHO says, assured, affordability comes as a first letter in that assured. And our country, we need affordable healthcare delivery systems. So again, I'll not go into the technical details, and somebody who is interested can approach directly. We can facilitate that with Dr. Bipin Nair. So these are technical details. I'll just skip those slides. Anyway, we're running short as well. So they applied for patency as well. And again, putting all prospective, patient being the center. You can see you have a glucometer, you have an insulin pump, you have an app, mobile app, which is a household device nowadays. You have cloud where the glucose levels are sort of stored. You have doctor, healthcare specialist looking after the patient. So the whole thing is comprehensively looked into now, with each gadget playing a role. And this snapshot of glucometer which they have developed, it has all the required tick boxes, whatever you want. You have error, you have alerts for low and high sugar. It even gives an option whether it's a fasting or post-meal sugar, what you are checking, so that the doctor sees with that comment when the sugar levels are sent. So they have gone to look into other aspects, other lab parameters as well. Bilirubin is one, cholesterol is another, uric acid is another. So lab on chip, it's something like 20 years back, you had only a landline phone. Now you have mobile phone with so many functions doing, and in the same way you have a chip with lab being mounted on it. So I mean, it's all when you again, Dr. Naukant Bhatt will understand probably very lucidly that this is all nanotechnology. Again, you take 5 ml and run through a lab test, go to a nano ml and put it on the prototype, whatever is what my understanding is. So lab on chip fabrication models. So that bringing multiple tests onto one strip, and especially this will help in the rural settings where to set up a lab facility to run every day, you need manpower, trained people. Training is a long process. All this is cut short. So they've even gone to look into cancer biomarkers, CA125 and ER, which is a breast malignancy tumor marker. And they've moved to paper-based diagnostic devices as well. So a lot of work Amrita Institute has done. And again, liver blood test, you get by color code a set value, which becomes a very good screening tool in a peripheral center. So this they've gone to make as a device, even bacterial detection. So they moved from biochemistry to microbiology as well. So, and during COVID, they've used again the same technology to look into viral load, and they've done a study to see nitrous oxide having an effect on COVID. You can, if you see that last part, the control arm, they were diseased in red, whereas people who have been given nitrous oxide, nobody died from COVID. So this is the team, Dr. Nair's team, and thank you.
Thank you very much, Dr. Satish Babu.
I just forgot to tell Professor Naukan, but also a similar path showed the multiple strip testing domain, and it is nice that he chaired this session. Thank you.
Thank you. Being an endocrinologist, you could really do the justice presenting Dr. Bipin Nair's work, especially in the context of diabetes. What you saw, eventually we are talking of going to what is called artificial pancreas. On one hand, we say that we have made great advances in science and technology, but we are always marveled looking at natural systems. We have an amazing system, what we call our autonomous system. We have a glucose sensor within the body. We have an actuator which releases the right amount of insulin, depending on the need that arises, right? And we are trying to understand that and mimic that. The good thing is that we have made advances in technology where we can create devices at nanoscale, but this cannot happen in isolation, right? This can only happen through confluence of discipline, right? And that is where the clinicians, engineers, molecular biologists should all come together and begin the dialogue, right? We have a lot of opportunities going forward. So that was in the context of what nanotechnology and engineering can do for healthcare. Hopefully, what we say, bridging the healthcare divide going forward. The other important technology intervention is from computer science, data science, artificial intelligence, and related areas. So that brings us to the next talk of this session. Dr. Raj Shah, practicing cardiologist, philanthropist, and also an entrepreneur. He is a CEO of Smart Care Doc in the US. He will talk about the topic, which is using technology to close the gaps, access the inaccessible, using the technology. I guess, again, he is not here physically. It will be a Zoom call or a pre-recorded talk.
Greetings. Can everybody hear?
Yes, we can hear you, Doctor.
Thank you. Greetings from city of Philadelphia, meaning city of brotherly love. It is 12:45 in the morning here. I'm delighted to be in front of you, an audience with amazing people. And I want to express my thanks and gratitude to Satya Sai University and Stanford University to put this together, an amazing seminar and part webinar, and particularly the staff at the Satya Sai University and Dr. Sunny Anand from Stanford, tireless work to put this together. Well, of course, as Dr. Sheshadri mentioned, the best is kept for the last. So here I am on the penultimate presentation, last but one. So all of you can take a sigh of relief that end is in sight. So let me begin. The objective of this webinar to reform medical education to provide healthcare that is affordable, accessible, comprehensive, compassionate, and culturally sensitive healthcare for all, especially underserved. But healthcare for all has been a lofty goal yet to be realized anywhere in the world, not just in India. The inequalities of the healthcare availability to particularly rural and underserved was brought and made very evident during pandemics. My topic, using technology to close the gaps, to access the inaccessible and serve the underserved, I want to make a compelling case to use technology to close the gaps. Now, the medical education is based on in-person patient evaluation and treatment. Throughout history, healthcare has been delivered in person. Availability of healthcare providers, cost, convenience, geographic barriers, availability of infrastructure, all of these pose challenges for patients to access healthcare. Access to healthcare has been a big problem everywhere in the world. Now, let's examine a typical rural and underserved area. Why they don't have healthcare? Well, they don't have healthcare providers there. There are no clinics, there are no hospitals. They may have to travel 10 to 30 miles. There are no pharmacies. They don't have medical supply or equipment. And even if it is there or it is brought to them, it may not be affordable because of the poverty. The statistic says that they survive on $1.50 equal to about 120 rupees per capita per day. And they don't have access to the providers, even if they want to go and travel to the next town, that there are no roads or transportation, no telecommunication.
Dr. Shah, you need to share your computer screen. We cannot see your slides.
Oh, I'm sorry. Let me.
It's the green button. And
yeah, I got it. I got it. I thought I was sharing, but that's my mistake. Hold on. Okay, I hope you can see now. So this was the slide I began. Can you see the slide now?
Yes,
okay.
Doctor.
Thank you. Sorry about that. So this was my introduction, which was very evident when I spoke. And I spoke about the medical education throughout history. It is in person. And then I began with this slide, that typical rural and underserved area, when you examine Why don't they have the healthcare? Because they don't have healthcare providers available. They don't have clinics, hospital, and even if they are there, they can't afford because of the poverty. And if they have to go somewhere else, there are no roads or transportation. These things make it impossible for them to get the healthcare. Also, the lack of good housing, clean water supply and sanitation, lack of electricity, lack of education, all these things compounds the problem. Now, the lockdowns and severe travel restriction have, during COVID, made this situation worse. So the challenge is how to deliver healthcare to almost 898 million rural Indians when you don't have doctors here. So let's then discuss different options. One option is to deliver care using mobile van. You can bring the doctor, healthcare workers to the village, but that's an expensive proposition. Cost of van, fuel cost, operating and maintenance, salaries of the doctors, support staff, loss of productivity from travel time, all this adds to the cost, and it makes it very difficult for them to afford or deliver the care. Let's look at another option, and I think that's a better option, is to meet this challenge of healthcare delivery using technology-enabled remote healthcare. Of course, delivering remote healthcare will require paradigm shift, because we all traditionally have been used to delivering care in person. Now we're talking about doing it at distance. Although for past 100 years, at least in some form, we are delivering care using telephone. But this modern technology makes it possible to add the video component and other technology, which makes it possible to replicate in-person visit. I was one of the early adopters of the technology for remote healthcare. I created telemedicine system and deployed in 2 Walmart clinic in 2012, almost 10 years ago. I built a system using computers, integrated devices, which we normally use to examine patient. We had a receptionist at the store. Patient would walk in, she'll put in the demographics information, take the vitals, text a message to the doctor. Doctor will come and see the patient, provide the treatment. And it was very easy, successful, validated the concept. We saw more than 1,000 patients, presented the data in American Telemedicine Association in 2012. We got the top prize. In spite of such a successful experiment, I had very hard time convincing medical communities and my colleagues. I must have given more than 500,000 presentations, but they said, oh, well, we are used to, this is our habit. We see patient in person. We can't do everything. So it didn't get the traction. But thanks to pandemic, now everybody is using video visit and telemedicine. In addition to just the computer, we can do the visit on the smartphones, and we can upload reports and images, video for video consultation and second opinion. We can also, this modality can be used by all the providers of Ayush modalities, Ayurveda, Yoga, Unani, Siddha, Homeopathy. And in these modalities, mostly no devices are needed, so it becomes very easy. However, even though we can bring the care, it is still expensive because the villager will need to buy smartphone, use hardware to have the devices, pay the cost for the monthly usage, and medical software. So this is still not a very viable solution. So let's look at how we solve this problem. I am chairman of Wills Global Foundation. It is a non-profit organization. We created with a mission to make healthcare access affordable by using technology-enabled, cost-effective heart centers. Now, the HEART acronym stands for Healthcare Easy Access for Rural Community via Telemedicine. And of course, the heart word is really dear to my heart, being a cardiologist. Let me show you how that will work. We will select one male and one female resident of the village. He must be a resident of the village. They don't need medical education or healthcare thing. The only thing needed is they can look at the smartphone, read the software, which is in the native language. They're taught how to use the devices, take vital signs. This will work, and this system, they learn how to operate. Thereby, they can screen the patient, take the vital signs, create a history. It has an artificial intelligence, machine learning, whereby 300 common symptoms are kind of analyzed into yes/no format, and they can prepare a report for a doctor to see at remote location. So it saves so much time. They can come and see the patient and provide the teleconsultation, also prescribe the medication. We give them a printer so it can be printed, and patient can opt in the medication. This system, we had to make affordable, not only affordable, but financially sustainable. So we paid the hardware cost of about $500, and we provided this kit with all these devices, which will serve a population of about 3,000 to 5,000, which could be in one village or a cluster of village, which can be easily, they can in a walking distance. Now the operating cost, which is about 110 rupees, $50, this is charged to the patient. Remember, we did not say free service, we made it affordable service. Now, 110 rupees is really a saving for the patient, because if they go out of town, if they have to stay there, lose their wages, it might easily cost them 500 to 2,000 rupees. While here, it will only cost 110 rupees, and the care is available at their doorstep, in their home or in their village. Now, this 110 rupees, we give 50 rupees to the doctor as a 5 or 10 minutes consultation fee. We give 30 rupees to telemedicine operator or Sahayak, we call. Now, this 30 rupees, if they do about 10 visits a day, that's a nice 300 rupees, almost 9,000 rupees salary. So not only we provided care, but we created 1 or 2 jobs. And 30 rupees goes to technology people to support and maintain and provide the care. Now, this fee can be reduced if a hospital or a charity clinic, say, will provide free care. That's that much less patient pays. There may be volunteers, then we don't need to pay salary to TMO. Then it only costs 30 rupees. Or maybe a university like Satya Sai University, they say, well, we'll pay the cost for software, then patient pays nothing. So in this way, there's always an amount available to sustain and maintain the system from one-time donation. Now, this is a very useful model, and we tried. In less than 6 months, we created heart centers of the Wills Global Foundation in 7 states, 315 sites, and we served more than 7,000 patients. Each site can see at least 10 patients a day. That means we'll be serving 3,000 patients a day. Our goal is to have enough donation to have 10,000 sites over next 2 to 3 years. That will allow us to serve 100,000 patients a day. My friends, that is the impact. And that is at such a small cost we are getting the highest bang for the bucks. Now, thus technology-enabled telehealthcare is the way to close the gaps and provide access to affordable healthcare to rural and underserved. We brought the access, we brought the affordability, and we made doctors available from distant villages. And this benefits both patients and doctors. Therefore, medical education reform that all our speakers have talked about at every level must include technology training for all healthcare providers. They have to feel comfortable. They have to learn how to use the technology, what are its limitations, what it can do. This should be part of their medical education training in every class, because this is the way we can close the gap and provide the healthcare when you cannot be in person. And I have to ask a question. Even if the doctors who come from villages, when they become doctor, when they become educated, how many of them, including myself, have gone back to the village to practice medicine? That's not going to happen in near future, because unless there are good living conditions, housing, sanitation, facilities, once they get educated, they don't want to be raising family in those villages. So no matter what we do, no matter how many doctors we educate, unless that is a long haul, we are not going to be able to solve that, provide healthcare workers living in those villages. And the only best way to me is the technology-enabled solution, one of the models that I described, which has been extremely successful. We started less than 6 months ago, and we'll continue to do that. Now, just a word in last 1 or 2 slides. Technology is here to stay. It is revolutionizing the healthcare delivery. AI, big data analytics, machine learning, virtual reality, nanotechnology. Look, just in last 5 years, we now have wearable devices which can monitor every kind of biometrics parameters, your temperature, your pulse, your oxygen concentration, your blood pressure. It can non-invasively detect the hemoglobin level, blood sugar level. All these things are going to be possible simply using smartphone. We can do wellness management, we can do disease management very easily, condition like hypertension or heart failure or arrhythmias, particularly atrial fibrillation, which is a high risk for stroke, and diabetes. All of this we can do using technology. And the future is not future, it's now. And to mention few, not only the wearable biometrics, but mHealth patch for home monitoring, whereby you can put a patch, each patient doesn't need to be in the intensive care unit. They can be monitored at home. Microsoft is working whereby they can detect, they can get the vitals, blood pressure, temperature, pulse ox, just by looking at the smartphone camera. We have robotics, which can do remote procedures, even operations. We'll have virtual touch. So those who are not convinced that, well, we must have patient in person and must touch and feel, you'll be able to do that using virtual touch. There are applications for contact tracing, something amazing, flying microchips, which can be just like a butterfly released in the atmosphere and will do population surveillance. Smartphone lab, a small credit card device attached to the smartphone. You can do so many tests at point of care, getting instant results. So the future is now. It is happening. Tech giants like Microsoft, Apple, Google, IBM with Dr. Watson are expanding their footprints in every sphere of healthcare. E-commerce giant, Amazon, Walmart, they are already started healthcare delivery online. Big pharmacy chains here in America, like CVS and Walgreens Boots, have teleclinics on their premises. And I just listened to Elon Musk of Tesla. It is predicted that artificial intelligence will be as smart or smarter than humans, and it may make all of us doctors irrelevant. Isn't it a scary thought? So let's take charge of our future and expand the medical education to include all aspects of technology. I'm going to leave you with this last slide. This is the picture of my graduating class. I graduated from Baroda Medical College in 1968, about 52 years ago. Here I am. I studied medicine in the books, all the charts, and writing prescriptions and simple stethoscope. This is my lecture room. This is how our children are studying or will be studying medicine. They won't be using books. It will be all on the smartphone or iPad or in computer. They won't be using the cadavers. They'll be using virtual reality to learn the dissection. They'll have virtual patients. They won't need to go to the clinics. This is the classroom of now or future. And my friend, this is how we'll be practicing medicine on the technology gadgets. And the last thing I would say, look at this. This is the medical office of the future. So thank you very much. Thank you very much. I don't want to bore you with this big slide where so many things are going to be needed before we really get our doctors into the villages. But this is, thank you so much for this opportunity. I hope I made a strong case to bring technology in our medical education. We need to change. We need to shift the paradigm. We need to start believing in remote healthcare. Forget about in person. Thank you so much.
Applause for Dr. and the IIT alumni who make up the Wheels Foundation and have brought out this amazing out-of-the-box solution that has so successfully helped to address the challenge of providing accessible, affordable healthcare to large segments of our population who live in remote areas. Now, I think people like Dr. Lal of the National Board and Dr. Gangadhar of the National Medical Commission will have to recruit as faculty people like Dr. Bhatt and Dr. Shah on to teach medical students in medical colleges. So technology is here to stay. And now we come to the final talk of this conference. And the topic echoes what revered Sadguru Sri Madhusudan Sai stressed upon in his inaugural address, the importance of the spiritual dimension of health. To talk of the urgent need to impart ultimate intelligence, that is IQ, EQ, and SQ, or spiritual quotient, we have a brilliant speaker from Chennai, Dr. Preetika Chari. She's a neurologist and a neurosurgeon, an expert on neuro-linguistic programming, an entrepreneur, and a life coach. Without further ado, let me hand over to Dr. Preetika.
Namaste to all of you. I was getting a little anxious being the last speaker because such fantastic speakers have presented such wonderful material throughout the sessions yesterday and today. At first, I every day in the morning, I do what is called as a blessing ball of light. I bless myself and I bless everyone. So let me start my presentation by offering a blessing from me to each and every one of you for the best health that you can have. To say complete health is a bit of a, it's not very realistic. So may I bless you all with maximum health at every stage of your life, so that the seva that you do reaches many more people. My slides are not in order. That's not my first slide. The second slide is, no, this is an old presentation. The new presentation has not been loaded. I sent Sunny Anand the revised presentation. Anyway, I'll see how best I can work with this, because we don't have time anyway for changing things. Okay, I'm a neurologist, so we'll start with understanding how the brain evolved. The brain evolved initially as a survival brain. It's called the reptilian brain. And then it became an emotional brain, the second layer, which was capable of emotion, which was capable of fear, love, maternal instinct, etc. Mammals are those animals which give birth to live births. They don't lay eggs. Reptiles lay eggs, and reptilian brain is about survival, eating, digesting, excreting, etc., reproduction. Then the last brain to develop was called the neocortex, or the outer brain, which is why we as humans have a big share of neocortex and we survive and do what we do. Now, there are two stages of optimum development of the brain, which occur first between 0 to 5 years, even up to 7 years. And the second growth spurt is between 12 and 21 years. What we put into these brains during these years, when they are eager to learn, those brains are just like sponges. They learn whatever is put into them, determine what we become as we grow older. Now, if you look at the second growth spurt of 12 to 21 years, many of our medical students are in that age group. And it's an enormous responsibility becoming a doctor. But it's an even bigger responsibility for those who train doctors. So we have to be very cautious and very conscious about what we put into these brains when they come under our care. Because judgment is the last to develop, and it is from the prefrontal cortex. Now, developing this judgment is something that we have to guide along the right path. So we have to make these young brains learn everything about life. And so Dr. Teresa's presentation resonated beautifully with me, and it's very important for us to teach those 5 life skills and many other life skills to our students. See, we have 3 types of intelligence. IQ is our rational intelligence. Most of us do a brilliant job in medical education because we're teaching them the duty, diligence, skills, all that. EQ is our social capital, and that's our emotional quotient. And last but not least is this SQ, which is the spiritual quotient or the spiritual capital. Now, unless all these 3 are in alignment, what I think, what I feel, what I am, this is very, very important for us to understand that if we are going to be a doctor. So the whole person okay, it's skipping slides. It's just keep going. Okay, we'll leave that. So people often associate that the great thinkers are because they do rational thinking. But actual strategic thinking depends on your understanding of who you are, why you are here, what you're doing, and how you're doing it. And that is why it resonated beautifully with me, with what Sadguru said yesterday, that the spiritual element is extremely important, and I should be comfortable with who I am and why I'm put on this earth to fulfill my role by God. Now, many youngsters are not quite sure why they are becoming doctors. When they come into the medical profession, when you ask them, why do you want to become a doctor? They say to serve humanity, to, things like that. But they're actually not quite sure in their own minds. So if they have a deep desire, see, I wanted to be a doctor from the age of 2. So if they have a deep desire to serve and to play their role, it's not moving at all now. It's not at all moving. Oh dear. Okay, well, I think we'll have to manage without the slides. And this is what can happen to you when you're seeing a patient. When you go out, suddenly everything around you will not work. And as a doctor, you're taught to be autonomous. You have to save the life of that patient. Nobody is going to come and help you. Okay, so don't worry about it. Just get down and do the job you're supposed to do with the skills you have. So in a way, I'm glad this happened. And in another surrogate way, I'm glad that I have a great collection of audience, because after me, Sadguru is going to talk. So all of you have come for him, but you have to listen to me before you have to listen to him. So, but let me tell you what the final message is. That a person is not complete unless they have a blend of the intelligence quotient, the emotional quotient, and the spiritual quotient. These three together constitute the social quotient, or how we carry on in life. Now, emotional education is also called emotional literacy. When we impart emotional literacy into people, what they can do is they become comfortable with themselves. They know how to manage their feelings. They become very comfortable with managing the feelings of others. See, when I became a doctor, 1971, I finished my MBBS. Nobody taught me that if I lose a patient, how I should handle it. So when the first patient I was taking care of died under my care, I whipped myself for 6 weeks. I felt guilty. Maybe I didn't do enough. Maybe I did something that misfired. Maybe I should have called somebody else to help me. There were a lot of doubts and fears in my mind. Now, what we feel we have to equip our medical students is that aspect of it. And during COVID pandemic, it became very obvious that the burnout among healthcare professionals was very high, because we are taught that though yesterday we were told ability versus nobility, I think we have been suffering under the burden of nobility too long. So everybody expects us not to have a life. We're supposed to make sacrifices. We're supposed to be there all the time. We're supposed to do everything everybody wants and forget that we exist. Please never forget that you exist. Love yourself, nurture yourself, cherish yourself. Self-care and resilience, which Les Ostner talked about yesterday, resonated beautifully with me. And I think it's very important for us to teach our medical students self-care, because emotional literacy and self-care is at the core of resilience. I'm a cancer survivor. I had, out of the blue, December 2016, I was diagnosed with cancer rectum grade 3. Now the survival rate in 5 years is 35 to 50%. So my first slide said, I'm grateful to the divine for being able to be here. I'm thankful to the organizers. I'm thankful to the organizers, to Dr. Sunny Anand, Stanford University, Sri Sathya Sai University. It's okay. It's okay. I'll just manage. Because sometimes when these challenges occur, they occur for a good reason. See, I didn't put I'm a cancer survivor. Maybe that was important to tell you today. So the divine has decided that this is what I should tell you. So that's fine. And let me point out, see, I felt blessed. I blessed all of you. I was grateful. I'm thankful. And since the slides are there, we'll try playing them. Again, it's gone. Doesn't matter. So what we need in life is a balance between our mind, our soul, our heart, and our body. And like Sadguru said yesterday, heart first, head and hands later. Soul always. So we need life enrichment. We need personal development. We need performance improvement. So if you have emotional literacy skills, you'll be able to label your feelings, which is very important. I must know why I'm feeling sad. And is it sadness? Is it disgust? Is it hate? I must be able to label my feelings. I will understand the gradation of my feelings. I will recognize facial and physiological changes in my patient and in whoever I communicate with. And I will modulate the response that I make to this person. So, and you develop tremendous coping strategies as I did. So when they diagnosed cancer in me, I was not afraid of dying. I was not afraid of the cancer. I'm a single woman. I live alone. I have 2 sisters whose health is not as good as mine. I was wondering who's going to hold me when I'm puking from chemotherapy? Who's going to help me when I go for radiotherapy? Who's going to be there when I undergo an 8.5 hour head down position surgery? But the blessings that I've been sending out, my patients' blessings, the love I've been sharing, so love all, served me well. Because every day blessings were pouring on me. And honestly, I do not know how I made this recovery. I just trusted God. I said, look, you've given me a job on earth. I've been doing it all these years. You want me to continue doing it? You do what needs to be done to make me okay to continue doing it. If you think I should settle down, I'll settle down. But please help me with the pain and the suffering, which I will try to bear if you think it's necessary for me to bear. Just give me the strength to bear it. So always the ABC of an emotionally illiterate person is to avoid, to blame, to complain. But the ABC of an emotionally literate person is always be connected. Always. And that is what, because we are dangerous when we are not conscious of our responsibility for how we behave, how we think, and how we feel. So don't become a dangerous doctor. Become a sincere, devoted doctor who's physically energized, mentally focused, emotionally connected, and spiritually aligned. And that was the main message for today. So I tell all of us, both the teachers and the students, physician, heal thyself. First, make sure that you are capable, you are good, and you have all that is needed. God will take care of the rest. As long as you do your bit, surrender and have faith, patience, and always be connected. Thank you.
Thank you. Thank you very much, Dr. Chari, for that wonderful lecture. And, it's just amazing how you connected eventually everything to the brain and, how we feel. And it just reminded me of a book that I read about 6 months ago, written by a Harvard Medical School faculty. The book is titled Cured. I think you should read that book. It's an amazing book. The whole book is about survivors of various diseases who the conventional medical wisdom thought they will never survive. It all happened because of the belief system. That's extremely important. And of course, there are various other things. It's an excellent book. It just reminded me, such a touching talk that you have given. Thank you very much for that. So that brings us to the closure of this fantastic session. Unfortunately, we have been told by the organizers that there is no Q&A session because there is no time for that. I request my co-chair, Dr. Sheshadri, to summarize this session and formally close this.
In summary, we truly had an amazing out-of-the-box session. Dr. Teresa Katz and Dr. Pritika Chari touched on the importance of emotional and spiritual health. And as Dr. Pritika said, this
needs to be taught in medical colleges so that the junior doctors who come out will be healthy themselves and will be able to help their patients remain healthy and regain them and stay healthy. We had good news from the National Board, for Dr. Lal touched on the central theme of this conference, how to improve the healthcare availability in rural areas. So the National Board is going to take healthcare out from urban clusters to the hinterland of India, to the more rural areas, more underprivileged areas of the country. And technology is here to stay. We had the brilliant presentation by Dr. Raj Shah and the IIT alumni who have helped bridge the accessibility gap, the affordability gap. And we had out-of-the-box solutions for numerous problems thrown up by Dr. Bipin Nair, presented so beautifully by Dr. Satish Babu. So we need to have all this as part of medical education. Medical education is being revamped, and I think we have Dr. Pavnendra Lal who can take back this message to all the powers that be in Delhi. And that brings us to the end of the last session of this beautiful conference. So I think we can close the session here and wait with all eagerness and reverence for Sadguru Shri Madhusudan Sai.
Thank you, ma'am. I'd like to extend our gratitude to all the panelists, to the chairs, and all the delegates in person and who've joined us virtually. It's very inspiring when we have medical specialists, industry experts, and policymakers coming together to sort of see the way ahead for medical education, particularly in this topic where the focus was on the social aspects. My gratitude to Dr. Pritika for highlighting how we need to look at a doctor as an individual in a holistic way, where she spoke about mental wellness, spiritual connectedness, social connectedness. And what a lovely way to end the conference where she said, surrender, faith, and patience are the three key aspects that a doctor should focus on. Thank you to the panel. I'd like to share that for all the delegates, the certificates of appreciation would be mailed to you soon. And the credit points could be accessible on the site bit.ly/ICFME21. With this, we close today's technical session. We have a short break of 10 minutes, post which the founder would be here for the closing remarks. Thank you. Saira, Swami has arrived here. We request everyone to kindly maintain silence. Welcome back, everyone. We have just concluded the 4th session of the International Conference on the Future of Medical Education 2021. We would like to welcome the dignitaries seated on the dais. Dr. Pavanindra Lal, Executive Director and CEO of the National Board of Examinations in Medical Sciences, New Delhi. Shri P.L. Tapadia, Vice President, Kasturba Health Society, Sevagram. Dr. B.S. Garg, Director, Professor, Department of Community Medicine and Director of the Dr. Sushila Nair School of Public Health, Mahatma Gandhi Institute of Medical Sciences. Dr. K.S. Anand, Professor of Pediatrics and Anesthesiology, Stanford University School of Medicine, USA. Shri C. Srinivas, Chairman, Shri Sathya Sai Health and Education Trust. Shri B.N. Narsamurthy, Chancellor, Shri Sathya Sai University for Human Excellence. Dr. Shrikanta Murthy, Vice Chancellor, Shri Sathya Sai University for Human Excellence. And Sadguru Shri Madhusudan Sai, Social and Spiritual Leader and Founder, Shri Sathya Sai University for Human Excellence. Over the last 2 days, we have discussed and deliberated on various aspects of medical education, undergraduate and postgraduate medical training and research, integrative medical education and training, social aspects of medical education and training. The distinguished panelists shared their views on the current challenges, innovative models, approaches of addressal, and the way forward in order to achieve a need-based and holistic medical education driving universal healthcare access. We now request Sadguru Shri Madhusudan Sai to give his closing remarks.
Our scriptures say, Dharmartha Kama Mokshartham Arogyam Moolam Uttamam. To attain the 4 goals of human life, which is for all, irrespective of whether you're a man or a woman, whether you're born in one kind of family or the other, the Indian way is 4 goals for every human life. Dharma, Artha, Kama, and Moksha. Dharma is to live your life in a righteous way, by all moral principles, social behavior, conduct, and of course, being on the right side of the law at all times. Dharma, to do the right thing. Artha, to earn wealth or anything else that is needed for you to sustain yourself, your family, your life. So, but it also means that only on the basis of dharma should you earn artha or money in righteous way, in moral ways. The third goal is kama. With that wealth that you generate out of righteous means, you fulfill the right kind of desires. Desires that will lead you towards the next goal, which is moksha. And moksha, though, is the most misunderstood word and interpreted by everybody in different ways. For me, moksha is simply dropping of all attachments. Moha kshaya. There's no attachment to anything. You are completely involved, interested in everything, but you're attached to nothing. But that happens when you grow spiritually. So these are the 4 goals. But to attain these 4 goals, the most important basic requirement is good health, is what the scriptures say. Arogya. Arogya also has another word in our system, which is called swastha or swasthya, as we call it. And swastha means swa, self. Stha means to stay. In that state of self, when you stay, when you abide in that state of yourself, that's when you are healthy. And what does that mean? What do you mean by being in your own self? And that was the discussion that we were interested to listen to. I think I heard the last talk on the YouTube video, link sent. Dr. Chari spoke about the different kind of intelligences, different aspects of human personality. And there she talked about emotional quotient, not just the intellectual. Intelligence, everybody, all schools talk about IQs. But EQ and SQ, more importantly, the spiritual quotient. So when we abide in that spiritual self, that is when we can be truly healthy. That is what our scriptures would believe. It does not mean that we don't understand the importance of physical health or mental health or social well-being, but most importantly, if we are connected to our inner self, who we truly are, then we are always healthy. There is no conflict within, there is no confusion. We are always at peace. And today's sessions, as I was listening to before coming, thanks to the technology, you can virtually attend any conference from anywhere. You can speak, you can listen. So I heard some of the talks and I was very, very impressed and also felt very happy that though these eminent doctors are trained in the modern system of medicine, yet they have such deep spiritual understanding of a human personality, and they are the hope for the future of medical education. I would personally like to thank all the participants who have made it here and also joined us on the Zoom call to attend this conference on behalf of the university and all the members of the university, staff and students. Special mention to Dr. Sunny Anand, who and his team have painstakingly put together this conference. And he brought some of the best minds from varied fields of medicine. And it was not an easy topic. You talk about integrative medicine, a hush-hush thing generally in modern medical parlance. But it was a bold topic to discuss. And he brought several people to address that idea. We also have some of the eminent panelists who are here today. Dr. Lal is here. They have done some path-breaking work in, as he puts it, peripheral training in medical education, taking education to more and more people. And we discussed yesterday, the only way to make education, healthcare accessible to everybody, the universal health access, is by providing health education to all, by making it easy for people to study medicine. And DNB has exactly done that, as I was able to understand. They come up with some innovative diploma courses, even before DNB courses, or do you postgraduate courses. And that's a big boon, because I personally have seen a lot of our students who have done MBBS, they struggle to get a PG seat, because the number of PG seats are not even half as much as the number of UG seats. The graduates who come out from UG, they don't even, 50% also don't get chance to study PG. And in that area, I think DNB is doing a great work in terms of providing accreditation to various other hospitals, which are not necessarily medical colleges, but capable of training and teaching. And I would like to congratulate him for this work, especially bringing the new courses in diploma. It will help a lot of students, including our own MBBS graduate students, who are very keen on studying and working, but then they don't know how to go about it. So that's a very, very important work. And the other side, I also have two eminent senior members from Mahatma Gandhi Institute, Varadha, Sevagram, and Dr. Garg and Dr. Tapadia. Both of them have been pioneers in providing healthcare at the doorstep of the rural households. India is largely a country which lives in its villages. That's what Mahatma Gandhi said. And it is on that ideal of Mahatma Gandhi that healthcare should be provided to everybody, it should be accessible. And this was one of the first institutes which started functioning on this idea, that how do we take medical care to the rural geographies of India. And I had the privilege of visiting the institute just a month and a half ago. And it was wonderful for me to see that the spirit with which they had started long, long ago by Dr. Sushila Nair, who was the contemporary of Mahatma Gandhi. And now they continue the same service. Many more children are getting educated. And we as a university we have pledged to support their work in terms of giving opportunity for more and more rural students to study in their institutions, and by instituting a scholarship scheme. So that is another great news. That's why they're here to discuss how do we go about helping more and more children access healthcare education. while yesterday we discussed how to make healthcare accessible by making it available, affordable to all the people. One important thing that we have experienced in our own little work that we have done in rural areas through medical camps or through hospitals is there is a dearth of trained professionals in rural geographies. While most of the students do study MBBS, not many are willing to work in rural areas. There are various reasons. One, because they have spent so much money on studying MBBS, so obviously they have to recover that. Their parents would ask them to. There is social pressure, there is a debt component to it. So how to make it cheaper, inexpensive, affordable was the discussion yesterday. And many policymakers also talked about it. And it was heartening to know that the whole government machinery is thinking on these lines, and they're trying to do whatever they can to make it more accessible and affordable, which is very, very important for serving a country like ours, especially after the COVID pandemic. All the gaps in the healthcare delivery systems were seen. They were wide open for all to see. And that's where bridging the gap through technology, through training, through making such kind of courses available to more and more children is a very important step for a country like ours, and also for the whole world, because most of the world lives in small towns and villages, and most of the big health infrastructure is restricted to urban areas. Specialists also live in urban areas. So how technology is taking this to rural doorsteps is a very, very nice thing. And last year with COVID pandemic, telemedicine becoming a kind of a recognized service was an important step in making healthcare available to the rural people. We, as our students and some of our staff and members of our medical fraternity, they also set up a telemedicine system where thousands of patients were counseled on the phone, because that the time was such that even if somebody coughs, the first fear was maybe I have got corona. Even if it was a common cold or flu, the fear was that it's corona. So you know that's where the EQ and SQ kick in, because you actually for all to see. So these innovations in healthcare is extremely important at this point in time when we have such a huge population. We don't have enough doctors. Till we produce enough doctors, technology can definitely help us bridge the gap. But then at the end, it is about human touch. Healthcare is about human touch. Healthcare is about care. So we need to produce more and more doctors, nurses, paramedics who carry this humanness within them. They are not just intelligent heads, but they are emoting hearts. They are sensitive beings, and they are spiritually grounded. As we also heard, how many people commit suicides during their studies, and the burnout that happens thereafter, especially in pandemic times. Lot of people, nurses and paramedics, they suffer tremendous burnout. So what is the way to help them help the patients? There were discussions on that, ontological there's a coaching and things like that. These are very insightful discussions that happen. And I think as we plan to start a medical college where we want to bring all these ideas together, the best from the whole world, including the idea of integrative medicine, this conference has really shown us the way and also brought the right-minded people who can connect with each other and work together, co-create an ecosystem of medical education and healthcare delivery. And the biggest advantage I want to tell you is that we want to do it absolutely free. We want to break all the financial barriers. It sounds like an experiment, an audacious one. But I tremendously believe in the power of goodness. When we do something selflessly, when we do something with all our heart, with no other motive than to help somebody in need, as they say, the whole universe conspires to support such an initiative. And universe is already started conspiring. I can see it in this medical conference, that we have people participating from all parts of the world to support this idea. So dear children who are the future healthcare professionals, many of them might be, I want to convey to you that you have a huge responsibility on your shoulders. See, this education that you have got, thousands and maybe millions of others don't get it in the world. This opportunity to participate, to understand, to deliberate on these ideas is not given to everybody. And this kind of high-end conference with people participating from around the world, from policymakers to the most achieved medical professionals, it doesn't happen every day. So you're very, very fortunate, and I'm sure you have learned a lot from this conference, haven't you? Every one of you. So that is the idea. What can I say in the concluding remarks, but I can only convey our collective gratitude to everybody who has worked so hard to put it all together. Everybody has spoken from their heart with the only sincere feeling to help the society. We had some of the best of the minds coming together, and we are very, very grateful as a university, also as a community here, for having learned so much from all of you. I hope and dream of a day when there are no barriers in healthcare. You see, healthcare is achievable, accessible, available to everybody. Whoever needs it deserves it. That's the principle on which healthcare delivery should happen, healthcare education should happen. And I hope that day is not very far. On a lighter note, we had a music conference two days before this. And one of the eminent musicians said, when I went through the COVID pandemic, I did not take any medicine because there were no medicines at that point in time. Later vaccines and all came, but at that point in time, it was like you were trying everything. So he said, I tried 3 ragas and I cured myself. So he sang 3 ragas to himself. I'm talking about the holistic healthcare model. So doctors can be singers too. Doctors can be musicians too. And if it doesn't help the patient, it will definitely help themselves relax and de-stress. Because otherwise, many of the doctors go through tremendous stress. And I personally, not in our hospitals. Most of the hospitals here, Dr. Krishna Manohar is there, Subramanian is there. They have done 23 surgeries in the last 5-6 days. Dr. Shetty to join them. And all children are doing fine. And they're all from the rural households. See, they can't even dream of a tertiary care facility absolutely free of cost in a place like this. But I'm very happy that they work quite hard. And because tomorrow is 23rd of November, and that is the 96th birth anniversary of Baba. So they wanted to do their bit for it by doing 23 surgeries within the last week and offer it as their offering to Baba. So we are very, very thankful and grateful to you, sir. Just to tell you that how important healthcare and accessibility is. So I look forward to many more such events where we will come together to understand how to do it. We have discussed now how we have to operationalize it and at the grassroots level. That would be the effort. Every end is the beginning of something new. And so also, though this conference is coming to an end, it is also beginning a new era in how healthcare is given and received in our country and in the whole world. And I think this is going to be, as our Srinivas put it, a path-breaking effort, an event which will change the course of history, especially in healthcare delivery systems. So thanking you all once again and praying, Sarve Bhavantu Sukhinaha, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kaschid Dukkham Apnuyat. Let all be happy, let all be healthy, let no one have any sorrow, let all see only auspicious and goodness everywhere. With this prayer, I conclude the conference, and with a lot of happiness and a lot of satisfaction that it went off so well. Thank you.
Our gratitude to Sadguru for enlightening and reminding us all the true meaning of health and of being healthy, for reiterating to us the importance and impact of compassionate care in healthcare. We now invite Dr. K. Srikandamurthy, Vice Chancellor, Sri Sathya Sai University for Human Excellence, to propose the vote of thanks for the conference.
Good afternoon, ladies and gentlemen. I deem it a great honor to deliver the vote of thanks on this occasion of the concluding session of the International Conference on the Future of Medical Education that was conducted by Sri Sathya Sai University for Human Excellence on November 21st and 22nd, 2021. Sri Sathya Sai University for Human Excellence was founded by Sadguru Sri Madhusudan Sai in the year 2018 on the substratum of the ancient eternal wisdom of Sanathana Dharma that offers true education by reforming the current trends of commercialization of knowledge and heralding a new goal of divinization of ordinary humans. With this principal motive, the university is now thoroughly enthused to turn a new leaf in its chapter of education by opening new vistas of free medical education for rural, needy, yet deserving children based on their passion to pursue medicine and serve the society. This medical conference has been attended by over 700 registrants and directly contributed by over 21 leading experts of medical education from around the world to deliberate earnestly on the critical need of reforms in the current medical education system with the primary objective of providing affordable, accessible, comprehensive, compassionate, and culturally sensitive healthcare to all, especially to undeserved populations. The conference has brought out several ideas and programs that can facilitate the much needed national and international reforms in the format, scope, structure, funding, evaluation, and access to medical education and postgraduate training. For a conference of such magnitude to have happened in a seamless and successful manner, I submit our collective gratitude to our revered founder, Sadguru Sri Madhusudan Sai, our motivation and guiding force behind everything. My heartfelt thanks to Sri B.N. Narasimhamurthy, Chancellor, Sri Sathya Sai University for Human Excellence, and Sri Srinivas, Chairman, Sri Sathya Sai Health and Education Trust, for all their guidance and support in making this event a grand success. My heartfelt thanks to all the dignitaries on the dais and off the dais for having graced this function despite of their busy schedule. Special thanks from my bottom of my heart to Dr. K.S. Anand, Professor of Pediatrics, Anesthesiology, Perioperative and Pain Medicine at Stanford University School of Medicine, for his tireless efforts in bringing together luminaries from the field of medicine and coordinating the entire conference to bring forth the resultant strength, decision, and action. To all those unseen heroes who worked behind the scenes selflessly yet silently, much gratitude. Last but not the least, to each and every person who has directly or indirectly participated in this grand event and made it a memorable one, our sincere thanks. With a prayer from my heart that we get more of such wonderful opportunities to serve our Divine Master by serving all, I conclude. Thank you very much.
Once again, a heartfelt gratitude to all the panelists, chairs, delegates who have joined us both in person and virtually. With this, we conclude the technical chair sessions of the conference. Thank you all very much and have a good day.